Firstly, in behalf of PALES, I would like to welcome you, Professor Petrovisa, and the rest of the speakers to the annual convention of the Philippine Association of Laparoscopic and Endoscopic Surgeons. It is unfortunate that we could not host you personally here in our beautiful country due to the ongoing pandemic. Nonetheless, we are truly grateful that you could join us here today. Now, everyone who remembers the best of his education remembers not just the methods and techniques, but more importantly, the teacher had taught him well. This is how fondly I remember you, Professor Petrovisa. You had introduced all possibilities of laparoscopic and as well as thoracoscopic surgeries. Moreover, as far back as I could remember, not only did you involve yourself in the surgery, but also in innovations. The PICO, do you remember the PICO that you innovated as a hand instrument for open hand-assisted surgeries back in 2004? But without further ado, it is such an honor to introduce you. Professor Andrea Petrovisa graduated magna cum laude in the University of Pisa Medical School, where he also did his surgical residency program. From there, he did this research fellowship program in liver transplant at the University of Chicago and became a senior registrar in Dundee in Scotland under the chairmanship of Professor Sir Alfred Cusheri. Eventually, he became the assistant professor of surgery in Pisa under Professor Mosca, and as well as a lecturer in Dundee. In 1999, he became the associate professor of surgery in Pisa. And finally, in 2010, he became the full professor at the University of Pavia in Italy, where he is currently working. Among all his publications, research grants, he is also an editor of the following journals: Surgical Endoscopy, Updates in Surgery, and Computer-Assisted Radiology and Surgery. And to add to his very busy schedule, he is currently the president of the European Association of Endoscopic Surgeons. Today, to give you talk on 3D technology applications in MIS, I give you Professor Andrea Petrovisa.
Well, thank you so much, Don, and thank you, Alfred. I'm really touched. I never had an introduction like this. And it is true, Alfred, when you talk about brotherhood, that's the kind of feeling I'm having with you. And I think these hard times of COVID-19 probably strengthen us together more than ever before. We have been connected throughout the lockdown, and surgery and teaching and telementoring has been running better than in the past. So this is a kind of legacy that will take with us even for the future times. We discover the value of a situation like this. I mean, we never thought of virtual meeting in the past. So this is something that is gonna run by side of physical meetings, I think, for the future as well. And we just came out of the EAS virtual meeting, which was very successful. And I know it takes quite an effort to organize this. So let me also congratulate PALES for what sounds like a very successful event. Let's see if I can share my screen. Okay. Good. So the topic I've been assigned today is the value of three-dimensional printing for surgery, I would say, and minimal invasive surgery. Now, for those of you who are not familiar with the Italian geography, let me just point out where I am based. Pavia is a small university town, which is located very close to the city of Milan in northern Italy. It is one of the oldest universities in the country, being established in 1361. And it is still one of the most active academic centers of Italy. The manufacturing process of 3D printing is based on virtual computer models for the reconstruction of 3D solid objects. by the addition of material layers, such as plastic, resins, metals, ceramics, and many others. In surgery, the initial 3D virtual model can be generated starting from the DICOM dataset of a patient's CT scan or MRI or other volumetric imaging system. Now, the modeling of soft anatomical parts to teach anatomy was first practiced at Florence during the 16th century. The technique of moldage, as it is properly called, entails the depiction of human anatomy and different diseases using beeswax as its primary material. During the 19th century, moldage evolved into a very artistic representation of the human body and its internal anatomy. And it became popular to have these models available for medical students at many teaching institutions across Europe. Now, the growing interest today into 3D printing in surgery is testified by the number of papers being published in the last few years that show a clear upward trend. These reports are mainly focused on solid organs and major vessels, whose models are more easy to build. And the prevalent reason to create 3D anatomical objects have been reported to be surgical planning, education, and training, but also patient counseling. So the starting point is the generation of 3D virtual models through a process which is called segmentation from a patient CT scan. And this is an example of a Klatskin tumor, which is partially occluding the right hepatic vein, the right portal vein, and also a branch, the anterior branch of the artery that is dilated intrahepatic biliary duct. In the past, we have also explored the possibility to fuse these 3D models in an augmented reality environment. Now, this video dates back to some 15 years ago. These are the grandfather of Google glasses, whereby you were able to see in transparency the patient, and you were able to see in 3D the internal anatomy. However, these attempts, at least in my hands, had significant limitations, such as the precise matching between preoperative imaging and intraoperative view, intraoperative shifting, and after all, accuracy. So more recently, we decided to look into 3D printing, and we were able in 2018 to establish our first laboratory for 3D printing at the University of Pavia. This is a view of the laboratory. This is also an exposition area for visitors and patients that explains why we are printing objects with the laboratory, which is fully equipped with industrial 3D printers. And we have 3 biomedical engineers working full-time for the hospital, not just for the Department of Surgery. And we learned along the way that many specialties can benefit from the existence of a 3D printing laboratory. Not to forget the many interesting productions that was put into practice during the COVID times. We were able to manufacture small pieces for our friend anesthetists in the ICU who were in need to solve technical problems. And in fact, as I mentioned, it is not the laboratory 3D format. It's not working just for the general surgeons, but also for cardiac surgeons, vascular surgeons, ENT, orthopedics. And these are some examples of the products we were able to produce over the past few years. This is an aorta with a metallic stent in place that needs some extra fixing on the part of our vascular guys. This is a complex hip fracture. And again, the availability of this model the day before allowed the orthopedics to decide which type of plaque and screw they would need for fixing, and also test on this model beforehand. This is a orbit defect, post-traumatic orbit defect, and the prosthesis was again printed with a metallic printed before surgery to make sure that it fits exactly the defect. This is a printout of the pulmonary arteries, and our cardiac surgeons were in need to remove this aneurysm, and we need a clear roadmap on where to go and what to do. Again, neurosurgeons, this is an intracranial aneurysm, which with a very complex feeding vessels, and they would prefer to have this in their hands as opposed to the conventional CT scan, or even, if you wish, a 3D reconstruction on the monitor. This is a lung cancer. Our thoracic surgeons fellows are also, I would say, a good customer of our laboratory. Every now and again, they ask for printouts of difficult cancer in the chest to be resected. When it comes to liver surgery, it is a bit more difficult because of the transparency which is needed to see the internal vascular anatomy, and because of the density of this plastic material, you get some deformation. So another way to get around this problem is to create interlocking parts that you can open up and watch the inside, something that we do with livers and with kidneys. This is another example of a very complex recurring intravascular tumor to this liver after an initial hepatectomy. You can see in purple this recurrence at the joining of the middle and right hepatic vein and plunging into the IVC. And this is the specimen, and we had to remove a segment of vena cava, and this is a type of reconstruction that is mutuated from liver transplantation, a piggyback technique with replacement of the IVC in that part. But again, the model we created for this proved extremely useful also for the pre-operative briefing and planning with the anesthetists and the cardiac surgeons. Makes everybody align on the program, and it was very clear the sequence of clamping and perfusing that was needed to accomplish this procedure. Today, as you know, the total mesocolic excision for a right hemicolectomy has seen some growing popularity, and the anatomy is extremely variable from one patient to another, and it's hard to understand by watching a simple CT scan. So we produce these models for central mesocolic excision, and the surgeon can bring the model to the OR and having very clear and understandable what type of venous vessels he has to dissect and how to proceed on top of the pancreatic neck to towards the middle colonic vessels, which is the final step of this procedure. And other hospitals are asking us to produce these models for the value that they also perceive in having them available for complex surgery. Now that was so as to say the bottom line of 3D printing, producing hard reproduction of the anatomy of interest. But technology progresses very quickly, and we now have a new type of printers that produce soft materials. And we can decide the degree of stiffness of the printout we produce in order to simulate exactly the mechanical performance of the printed objects. And that opens the gate not just to let's say, planning process. And we took one step forward, and it's not only planning, it is planning and it is simulation for training purposes. And here is an example of the consistency of the stiffness and softness of the material we can produce. It's the left kidney with the vein, with the aorta, with the two arteries. And this kidney is meant for a laparoscopic nephrectomy for transplantation. So it's a donor nephrectomy. And the challenge here is to have two vessels instead of one. And so we need some bench reconstruction that can be done using this model. Here is another example, perhaps even more effective. This patient has an aneurysm of the splenic artery. You can see it now, close to the hilum of the spleen. And this is the 3D reconstruction on the monitor. And from this, we can print out the model with the soft material. And so the model is operated with the robot. And so we can anticipate the technical challenge of this procedure the day before. This is the real operation. And you can see how the splenic artery is transected before and after the aneurysm, and then how we can approximate the two ends for reconstruction. And the same could be done beforehand with the 3D printed model. So this is a type of simulation that cannot be available in different settings with different tools because it is patient specific. So you cannot only be able to simulate, as we are used to, a generic, let's say, cholecystectomy or nephrectomy or hepatectomy, but you can simulate on the patient specific model, which increases the value of this technology for training purposes and for teaching future surgeons and junior staff. And so obviously this is not yet applicable to all sort of laparoscopic surgery because of the difficulty to reproduce in 3D soft organs like the colon or the stomach, but we are working to that. And it will take some time, but again, the technological advancements are impressive, and we are now partnering with the leader of the market in 3D printing, and we are together developing a new type of materials and new type of techniques. And I'm going to show you something. So starting from this successful examples, we decided to take the challenge and see if a platform could be manufactured to train our junior fellows in kidney transplantation. And again, the bottom line is to be able to use a patient-specific kidney. So we have the CT scan of every live donor for because that's part of the protocol. And we can use that imaging to reproduce exactly that kidney with that arterial and venous peculiarity, and train someone in transplanting this kidney back. This is how our technicians and engineer were able to assemble this model. We have the bladder, we have the vessels. The vessels will be pulsating and perfused. You can see the sockets where we can connect a pump to reproduce a pulsation of these vessels. That is not yet in place, but it will be in the near future. And so from one case to another, we would only replace the iliac vessels and part of the bladder. So the segments that are needed for transplantation only, by leaving the rest of the model intact. So we don't have to rebuild everything every time, but just that segment which is needed for the transplantation itself. And that is the ureter, the native ureter. And that is our kidney for transplantation in place on the psoas muscle. And that's how the ureter will join the bladder. So that's basically the model. But then we had to overcome an additional trouble. And the trouble is that the consistency of the 3D printed vessel were far from ideal. So we had to add this trick by dunking the 3D printed object into latex to obtain a latex coating. Now, with the latex coating, the performance, the mechanical performance of this vessel, you can see on the right side, you know, the donor vein. It's pretty much similar to the real vein in terms of, again, mechanical performance, holding of suture, holding of knotting, and so forth. So we felt that this type of simulation was very much realistic, and we are now embarking into a project having our junior fellows exercising themselves, training themselves on this new model. And I'm going to show you the final video, which is this one. So the operation, let's say, are done in this OR, and we have the surgical team, the scrub nurse, everything is like real, but there's no patient. Anyhow, this is the fellow. She has to decide where to make the incision. She has to expose by displacing the peritoneum. She has to expose the vessels. Then the kidney is put in place. The excess renal vein is resected, and then the anastomosis is done. So there's one assistant, self-retractor. Everything runs like in the real life. And we have two fellows, and they are currently doing 20 transplants each. They shift over. One time, one becomes the assistant, the other times is the first surgeon. And so I'm not yet there, but I can anticipate that their confidence with the procedure has been greatly enhanced by this model, which is not simply a surgical skillness test, but it is also an environmental type of experience, because you have your scrub nurse, you have your assistant, you need to coordinate everybody and to keep in mind every step of the procedure in due time. So again, this in the near future will be done with patient-specific kidneys. Now, in conclusion, my perception about 3D printing is that this technology, new technology, is perhaps a very good way to deliver the morphological information from radiology to the final user, which is not just the surgeons. We have been asked models from cardiologists, from even from our pathologist and from our anatomist for teaching purposes. And today, or if you wish tomorrow, it could be used also for simulating procedures. We are using that not just for kidney transplantation, but also for liver surgery in difficult cases. Still, there are some open questions concerning 3D printing. The cost and time it requires to set up a laboratory, and it should not be a laboratory for you as a surgeon, but it should be for the hospital. It has to be seen as a facility for the whole hospital, like the pathology lab or the, any facility which is available to everyone. In that way, you reduce the cost by sharing the value. It is currently mostly limited to solid organ and major vessels. And of course, you need a good partnership with engineers and technicians, because that exceeds too much the knowledge of simple surgeons like we are. So I thank you very much. And again, it was a real privilege to be here today and to see the nice faces of my good friends, Alfred and Don. Thank you very much on behalf also of the AES. We appreciate our friendship. Thank you.
Thank you, Professor. Excellent presentation.
Thank you, Andrea, for a very nice lecture. Dr. Andrea Patrabisa is the present president of the European Association of Endoscopic Surgeons. We'll entertain questions after the three lecturers, so we can go on with the other lectures. So let me introduce the next lecturer. The next lecturer is not only an accomplished laparoscopic surgeon, but a very good robotic surgeon, a very good and expert endoscopist, no other than Professor Philip Chu. Philip Chu, at present, is the Assistant Dean for External Affairs of the Chinese University of Hong Kong. He's also the director of the Chinese University of Hong Kong Jockey Club Minimally Invasive Center, the training center of Prince of Wales. Also the director for the Center for Innovative Medicine. He's a co-editor for the endoscopy, subject editor for surgical endoscopy. He's the chief editor of the ELSA official paper, which is the Asian Journal of Endosurgery, and a very good friend of mine, Philip Chu, my brother. Philip, please.
Thank you. Thank you, Alan, and good afternoon, friends from Philippines. And I'm delighted to share with you my lecture. So firstly, I would share my presentation here, so which is endoluminal robotics, what's new. So can you see my PowerPoint? Okay, thank you. So I think the endoscopy has been actually have a major development over the past 60 years. So shortly, during the 1950s, there was a proposal of having an endo camera, using the concept of a camera that puts through a fiber optics that can take picture within your stomach. So that starts the diagnostic role of endoscopy. But if you look into the modern appearance of the endoscope, it is still a important component still there, like the importance of the light source, optics, processing unit, and the only thing that was added to the flexible endoscopy will be the working channels. But which part of the endoscopy can be improved in the future with technology? So I believe firstly, the image processing and analysis will be improved through the AI-assisted diagnosis. As you can see, that there has been the increasing application of AI to enhance detection for flexible endoscopy. The steering and locomotion may be improved with image guidance or sensing technology, or even the robotics. But one of the key issue for us with the flexible endoscopy is how to improve on the therapeutic side. So looking at the publication related to robot and endoscope, actually this is a publication from our unit 2 years ago. There's an increasing trend of association between robotics and endoscopy. And there are actually 3 areas that targeted to improvement through robotic-driven technology for flexible endoscopy, like the locomotive control system with automatrix locomotion, and also robotic-driven instrumentation. So in the area of steering and locomotion for endoscopy, I think robotics aim to reduce the pain and discomfort during the endoscopy, and also hopefully to reduce complication, and perhaps also to enhance the steering mechanism and to reduce the stress and workload induced on the endoscopists. And the technology will be a combination of robotics, imaging, sensing, and AI. And there are already quite a few systems being developed for enhancing the steering and locomotion. But one of the issues is that it's been developed for over 10 years, but still not applied clinically. One of the reasons is because we have very skilled endoscopists. So with these robotics and in helping the steering and locomotion being applied to the cost effectiveness, that is always the key issue. But I think in the next 10 to 20 years, with the increasing performance of flexible endoscopy for screening, and with the improvement in the quality and efficiency through AI technology, I think there will be increasing potential for therapeutic endoscopy. We have already seen the potential of therapeutic endoscopy since the performance of polypectomy for treatment of polyps. So arguably the early GI neoplasia in the GI tract, and then coming to EMR and ESD developed in the year 2000. And then afterwards, we have the concept of the natural orifice transluminal endoscopic surgery, and landed to the first phase endoscopy through submucosal endoscopy performed with the first procedure of POEM. And if you look into the recent percentage of new cancer and cancer death rate worldwide, colorectal cancer and stomach cancer has the highest incidence. So it is the 3rd and the 5th most common cancer. And if you look into the mortality, then colorectal cancer and stomach cancer are the 2nd and the 3rd. It means that we have a huge space to improve on the detection and also the outcome for the treatment for GI cancer. And I think all of you know that the best stage to treat this cancer is at the early stage. So if you can detect early GI cancer, then without lymph node metastasis, then the treatment is just a local treatment by endoscopic resection. And the first concept of ESD is being developed from Japanese endoscopists because at the very beginning, with the use of the EMR for treatment of early GI cancer, actually there is a high rate of local recurrence. So one of the ways to improve is to perform the ESD with a wide margin, and so that to reduce the local recurrence through on-block resection. So the ESD have the advantage of not only a locally curative intent treatment, it achieves a on-block resection, just like any kind of surgical treatment, but also it's an organ preservation. So the function of the diseased organ is preserved, so that the patient can achieve a better quality of life with a less post-gastrectomy syndrome, also a better post-operative outcome with a shorter hospital stay and early return of GI function. So we have conducted ESD training courses, and this is one of the outcomes from our training course, including gastroenterologists and surgeons in the training, where they performed the first ESD in the pig model. But notably that the first procedure of ESD, the perforation rate is up to 62%. So one of the reasons is because the ESD is being performed by just a single arm, and the arm is attached to your eyes, which is your endoscope. So that means you are manipulating your endoscope through the endoscopic movement. You can achieve the dissection. So this is kind of difficult in demanding your high endoscopy skill. But if you are looking into the development of minimal invasive surgery, now we are applying routine robotic for assistance, and also with the laparoscopic development of 3D. So there is a significant improvement in terms of the quality of the dissection, stability of the platform provided for a surgeon to achieve a high quality endoscopic laparoscopic dissection with a good oncological control and clearance. So can we apply the same technology to flexible endoscopy? So if that occur, then we need 3D or even 4K imaging. We would need better tissue retraction and for the dissection device, something like a multitasking platform, and also a tissue approximation device like a stapling or suturing for endoscope. So there has been already some system developed like this robotic system, and this provide a robotic flexible platform for performance of endoluminal dissection. Like here, this is a case of report for robotic assist ESD for colorectal lesion using the MED robotics. And currently, this is indicated for surgical access to the oropharynx, hypopharynx, and larynx. That means the ENT, and also at the anus, rectum, and the distal colon, because there is a significant limitation in the depth that this device can achieve because of the size and also the mechanism. And also, I think the ERCAT has also developed this system, the endoluminal surgical robotics for colorectal ESD. And this is actually a robotized development from the animbiscope. And this is a report on the ex vivo model for performance of ESD in the POSI model. So our team actually developed the master and slave transluminal endoscopic robot from Singapore and Hong Kong. So Singapore is from Professor Lawrence Ho from National University of Singapore. And he's a renowned gastroenterologist, and Professor Louis Fee, who is a renowned engineer from Nanyang Technological University. And I serve as the scientific and clinical advisor. And we developed this master robot. So first concept was actually from Professor Sidney Chung. When he visited Singapore and enjoyed this chili crab, he think of application of this crab core to the end of the endoscope. So with this development of the master system, we performed the first clinical trial of using this prototype robot arm, which consists of a retraction device and also a dissection device for submucosal dissection. So this system was built on a conventional double channel endoscope, and this is the first trial that we perform master ESD for treatment of early gastric cancer. So 3 patients from India and 2 patients from Hong Kong received this procedure. And you can see that this is more a concept from the surgical side. We have a stable platform, and with the use of the 2 arms, we can perform this dissection. So at the submucosa. So the surgeon is sitting over the other side of the bed. We still need endoscopists to hold the endoscope over the other side. So this system was developed into the 2nd generation. So this EndoMaster system has been developed to this 2nd generation, and we have redesigned the endoscope with the 2 robotic arms. And this is coming from the distal end of the robotic endoscope, and the scope can be parked on a robotic arm held over the console at the bedside of the patient. So it has a independently designed flexible robotic platform, and also with a built-in endoscopic imaging system and 2 channel for a robotic arm, and also with an accessory channel and independent water jet system. So this is the concept of the design of the current system. And so you can see that after parking stable at the target site, the 2 robotic arms will be passing out for performance of the ESD. So this is one of our animal study that we apply. This is a new system in the performance of esophageal ESD. So you can see that we can have a very stable platform, one arm for retraction, the other arm for dissection. And so we can see the submucosal plane very clearly, and then we can complete this submucosal dissection. So noting that in the esophagus, this is actually very narrow lumen. So even with this narrow space, this robotic arm be able to achieve a good submucosal dissection. And also we employed the concept that we can retract the mucosa from not from the sideway, but also from the caudal to the cranial side, so that we can push the specimen to the anal side, so that we can expose and perform the dissection. So this is the final cuts of the ESD. And we also applied this in the treatment of a colorectal lesion in the porcine model. So you can see that we can perform the first mucosal incision, and then we can expose the submucosa and checking on the deep submucosa and the muscle layer, so that we can perform this submucosal dissection like that. So a very similar concept, but in performing in the more like a surgical dissection. So we are now conducting a clinical trial for the colorectal ESD in the CUHK in Hong Kong. So I will be happy to report to you soon after the completion of this clinical trial in human. So, and also there are next development of a robotic system not only for dissection, but for suturing. So this is the system that will be able to perform the suture. This is still a prototype, but in future, we will be able to apply for treatment of GI emergency, morbid obesity, and probably full thickness resection. So this is the system, and this is the first suturing device that we applied for prototype testing in the animal model. So you can see that we can transfer the needle between the two forceps, so that we can apply the suture over one side, and then pull the needle, and then apply to the other side of the needle. And finally, we will be able to tie the suture. Very similar to the concept of the endo stitch that we have been using in the past. And I think one way is to we develop the whole, we reinvent the whole wheel of the technology. But at Chinese University, we also trying to apply the same concept of robotic arm, but using an existing platform. So this is the use of the USGI transport platform, and build in our own robotic arm for performance of ESD. So this is one of our animal model that we have tested the use of this two robot arm. So with a slightly different design as compared to the Singapore team, but the similar concept of performing ESD with retraction and also the submucosal dissection like that. So the endoscope is independently moving so that it provides us probably with a better view. So this is also tested in the animal model with a good success in dissecting a large size ESD in the porcine stomach model. So I think in summary, in the future, we believe that the endoluminal robotics will be a lead to combine the robotic system together with 3D and 4K endoscopic imaging, and also novel device for tissue approximation, suturing, and dissection to achieve a good endoluminal surgery. And I think in the future, with this technology, we can convert a lot of these laparoscopic procedure into endoluminal procedure for better patient outcome and care. So thank you very much.
Thank
Thank
you,
you, Philip.
Professor.
Don?
Yes, sir. Thank you, Professor Chu, for your a very interesting lecture. We appreciate it very much. I would like to introduce again our third and final speaker for today. Our next speaker has dedicated most of his life's work in surgical innovations. And looking at his curriculum vitae, his work has been mostly on startup and as well as integral part of surgical innovations. He's currently the founder and co-founder and consultant and board member in most medical device startup companies in Israel. A medical manager in a large private group practice dealing with surgery and interventional medicine. Is a large international network of opinion leaders in surgery, interventional medicine, medical device companies, and distributors, which includes the United States, Europe, as well as China, with a vast experience in teaching and simulation of surgical procedures. He's a pioneer also of the minimal invasive surgery in Israel. Currently, he is the Chief Medical Officer of Human Extensions. Good afternoon. I'd like to introduce Dr. Amir Schultz from Tel Aviv.
Hi, good afternoon, everybody, and thank you very much for the opportunity to present in this unique platform. It's actually the first time that I present in a virtual congress in this magnitude, and I think you should be praised for the beautiful thing that you've managed to do here. Let me share my screen. Just a moment.
Hi, Amir.
Hello, hello, hello.
Thank you. Thank you for joining us.
I don't see. Just a moment. Excuse me, 1 second. Why don't I see this? You have it?
Perfect. We can see
Okay,
it.
so
Thank you.
thank you very much. I'm going to speak about the future of the way I see the future of surgical robots. Just to give you an idea of where I am, Israel is a small country of a little over 8 million people living in quite an interesting neighborhood in the East Mediterranean. This is the hospital where I do my clinical work. It's a very nice new private hospital. Although I'm involved in a lot of technology, I still do 600 to 700 cases a year myself. So I'm quite busy. I'm not only talking theory, I'm involved in active surgery. These are my disclosures. I am the CMO of Human Extensions, a company which is making a robotic platform that I will show in my presentation, as part of my presentation. So when we think about robots, this is what pops into our mind. This is the production line of the Volkswagen Golf car. A lot of very accurate, very quick, but still repeated work, not something that's very smart, that can replace humans in performing faster, cheaper, more accurately, and do much better than manual labor by humans. But when you go to think of real robots, which are not only mechanical devices, you think of an information machine, which is a machine that can take the computing power of a very smart computer and manifest it into physical action. And there are some robotic systems, this is by Boston Dynamics, that are almost behave almost like an animal, like a smart animal. This is a robot that was asked to open the door, and you see that if it's being disturbed, it will still try to overcome the disturbance and keep on acting. Nobody's driving this robot. It's completely autonomous. It was given a task, and it will continue to do the task. So this type of robotics is very interesting for performing surgery, because if you can combine the brain of a very good computing system to something very, very accurate and fast, you can imagine doing surgery or interventions in a better way. There are a lot of new types of robots that we don't even think of them as robots, like drones that can stay in the air for 24, 48 hours and survey areas autonomously and come back to where they were launched from without anybody driving them. And then in our field, in medicine, there is a huge potential for robotizing a lot of things that I'm not going to discuss now because I'm going to focus more on surgical robotics. But if you think of it, nursing, a lot of what nurses do could be replaced by robotics. A lot of the hospital's logistics could be replaced by robotics. Pharmacology is an excellent example where robotics can tailor medications to patients, prepare the medications, and prevent human errors in giving and preparing the medications. And of course, rehabilitation, allowing passive motion, active locomotion, and assistive devices for patients who are recuperating from surgery. So these are all places where there's a huge landscape where there is a lot of place for innovation. Currently, what we have are a few platforms. The only one is that are actively on the market today are what I call furniture platforms, which are big robotic systems that stand on the operating room floor. There are some bed-mounted platforms that might come into the market. There is a handheld system that I will show you, and they can all be rigid, semi-rigid, or flexible. So we all know this. Not many of us own this, but we all know this. This is the Da Vinci system that is in the market for over 20 years already, and over 1 million patients were operated using this system. It has exceptional engineering, very intuitive learning, a very good human interface, and it's like an all-inclusive platform. It has the control, the manipulation, the vision, the electrosurgery, the stapling, the imaging, everything is included in one big and expensive, very expensive system. It has 7 degrees of freedom. It has 3D vision with the special resolution, very good resolution. And it has a pretty good ergonomics, although with surgeons doing more and more cases robotically, we find out that there are problems, that ergonomic problems from sitting with your head stuck in the machine that could be difficult also to tackle. But I think that owning a Da Vinci system is very much like owning a Bugatti Veyron. It costs about the same, about 2 million euros. It's fantastic to drive. It makes your life very nice and easy. People are looking up at you, but still it takes you from one place to another, and you need a surgeon to drive the system. And if the surgeon is bad or stupid, the machine will not prevent him from making bad surgery. And this is, I think, at the core of the discussion today. This is the newest version, the single port Da Vinci system, which is really exceptional, very beautiful. There is very little data showing that any of the current robotic system has translated into a better patient outcome. And the cost effectiveness model of that is very, very problematic, especially for countries that have in mind more than just the hospital or the hospital system, but the patient and society, on how we spend our money in terms of healthcare dollars. There are more competition coming into the market. This is CMR, a UK-based company that is making a smaller, slicker robot. Not many in clinical trials yet. It's just coming into the market today. The company has raised an enormous amount of money and is commercializing now. Another system is Senhance, which is struggling. And some companies are making single port devices that are waiting to come into the market. Some of them will survive and some of them are not. Some of them are having a very hard time entering the market. We know that the two giants of medical devices, Medtronic and Johnson & Johnson, are looking for entries using robotic system. This is DLR, a German company that we know that Medtronic has bought some of their technology. We don't know how the Medtronic robot will look like, but maybe this is a hint. This one is a bed mounted system. Another slick system that could be changed and moved. And we know that Johnson & Johnson has started a company with Google. They announced that they're going to be in the market in 2019. Then they moved it to 2020. And yesterday they announced that they think they will start clinical trials in 2 years from now, in 22. So it's not easy to make something like that. And especially if you come to a field where other companies already created a reality. But there's a very big space between a very large robotic system, furniture, console-based robotic system, to what most of us use today, which is a really stupid laparoscopic instrument that were designed about 50 years ago for ENT surgery. And I think this space requires us to be more innovative and think of other solutions, how to make surgery better, both for the patient and the surgeon. So actually when you look at the robotic system, you get dexterity, you get stability, you get 3D vision, and you get ergonomics. This is me after 30 years of doing minimally invasive surgery. My neck aches, my shoulders ache, my back aches, my arms ache. And this is something we have to think about also, not only the patient, by a surgeon whose body is in a good condition and standing there or sitting there comfortably is more likely to do better surgery. If you think of all these components, so 3D vision you can buy off the shelves. All the companies make pretty good 3D vision for laparoscopy and even for endoscopy. So why don't we build a robot that's like this? So like instead of selling a Bugatti Variant, we can send a small Hyundai for everybody to use as a small, smart robotic system. Several companies have attempted this, some of them more and some of them less successfully, but I think this is a very good direction to go to. This is a 10 millimeter system made in France. And this is a company, a Japanese company that went off the market because finally they found out that they were infringing patents of Da Vinci, so they're not available. And this is something we did in Israel. This is a company that I spoke about, Human Extensions, is making a very slick robotized laparoscopic instrument that gives you almost the same flexibility and maneuverability of a large robotic system in a very small 5 millimeter slick handheld device. The system I will show you in a minute is already CE marked and FDA approved, and the sales of the system started, unfortunately, just before COVID started in Europe. So now everything is stuck. In Europe, it's being sold by Esculap, and we're now trying to think of ways to distribute it in other countries in Asia and in the Americas. This is how the device looks like. It has a motor pack, and with the computing power, it has a very nice human interface, and it has a 5 millimeter tip that could be replaced by different instruments, needle holder, grasper, etc. And for me, it was something that I dreamed of about 10 years ago. And when we started this company, I mean, the biggest, and this is how you can see that the device moves exactly like your hand does. Your fingers open, close, your fingers rotate, and your wrist moving to all directions is imitated by the tip of the device. This is all drive-by-wire. It's all motorized and computerized. It could be remotely driven as well. And it has a lot of computing power and a lot of data acquisition. You can learn where your moves are. You can learn where the instrument is. There's a lot of stuff going on that I can't go into now. And the nice thing about it is that I've started working with that clinically. Currently, the device has a needle holder and the grasper, but a lot of instruments are coming soon. So now we can do we can perform human surgery using this device. And these are many examples from around the world of surgeons using it in different kinds of operations. Hernia, colorectal, intracorporeal anastomosis, prostatectomy for anastomosing the urethra to the bladder, bariatric surgery. So we've performed, I think, close to about 800 cases using the system in several centers around the world. And we're looking for more opportunities to bring this into the hands of many surgeons, because this system costs about 2 to 3% of a Da Vinci system, and the disposables are also much cheaper. So I think it's one way to democratize robotic surgery and make it available for surgeons around the world, and not only in very big, rich medical centers. I want to discuss a little about autonomy. This is a autonomous algorithm running a Da Vinci robot, and this is all done completely automatically. But I think that we should not hold our breath for autonomy in surgical robotics. Autonomy is not only a mechanical thing. There are a lot of questions and a lot of decision making that is being done while we're performing surgery that is very, very hard to drive by AI. So only a very well-defined task could be driven autonomously. I think that we are very, very far, as far from a fully autonomous car, we're very far from a fully autonomous robotic system. So I wouldn't think that it's a nice thing to dream about, but I don't think that we're going to see a truly autonomic robotic system in the near future. But what we're doing is we're moving from electromechanical system to something that I think will be like cars, assisted driving or assisted operated, then semi-autonomous, where we will automate very well-defined parts of the operation. And fully autonomous is maybe will come somewhere in the near future. We are somewhere here. And this is the barrier that I think we'll have to handle when we get to that point. And also, it's important to think that future is not an extrapolation of the present. So if we can come up with a technology that can suture autonomously, we can probably come up with a technology that will replace suturing altogether. Like, for instance, cardiac stenting replaced many of the cardiac operations where people were making devices for suturing cardiac operations, and then suddenly stents came in and everything changed. Robots can perform much better than humans in many tasks. This is, for instance, a very good example. The only reason is that they are much faster, and this robot actually reads the guy's hand and can figure out how to win all the time. And we're looking for something like that, not only for an electromechanical system that will translate the surgeon's movement, but something that will give us more information that will help us operate better. And for instance, one of those things is driving a camera. We all wish when we operate in laparoscopic surgery that we had something that will keep the image stable. And this is something that the robotized system can do very nicely. So this is a company that is analyzing constantly the video image, holding the camera, and following the surgeon's point of interest automatically. You can just tell it, go to that instrument or the other instrument. It can identify the instrument, it can identify the landscape, it can follow your instrument. And it's been integrated. It's in the company that I was involved with, been integrated into one of the robotic systems today. So what we really want to do with robots is to replace complex procedures and move complex motion into a simplified version that we can actually do very easily. I'll briefly say why I think this is important in the next steps of our evolution. So if you look at surgery, we are mechanically manipulating tissue. And some of the diseases are organ-based, but most of what we treat is not organ disease, but a cellular disease. So trauma, hernia, all these organ-based things, mechanical things, will probably be continued to be operated by surgeons. We have to fix bones, we have to close holes. This is still a very mechanical job. But when we treat cancer or infection, we can prevent it, we can detect it early, we can use new drugs and other modalities to get rid of these cells without actually removing a piece of the organ or the organ itself. So this is why the future of surgery is going to be something like this. We are going to approach a lot of the hollow organs using endoscopy, catheters, and capsule, and we're going to approach a lot of the solid organs using ablation instead of resecting the organs. So this is endoscopy. This is my friend Silvana Peretta from EARCAT doing a endoscopic, using a flexible endoscope transvaginal cholecystectomy, a procedure that took like 3 or 4 hours. And the reason is that the endoscope is not built to perform complex procedures. And this is me thinking, what is an endoscope? An endoscope today that we operate with is the tweezers attached over one of your eyes, and you're expected to do complex procedure using this device. And like Professor Chu said, this is unacceptable, and we have to come up with better devices. And I'm not going to go into it. This is Philip Chu's first prototype of a robot, endoluminal robot. And this is the latest acquisition. I'm sorry. This is the Monarch platform that was bought by Johnson & Johnson. And also, if you think of all the hollow organs in our body, there are actually highways to reach other places. If you can reach the kidneys, the adrenals, all these organs. And I think third space flexible endoscopy is another future that we have to explore, which means going into the lumen and then getting out of the lumen, not into the abdominal cavity, but into the retroperitoneum or into the chest, and perform procedures, mostly ablation there. And I think that probably ablation is another technology that surgeons have to learn how to control, not only flexible endoscopy. And there are different types of ablation technologies. And this is an example of another ablation procedure. This is another Israeli company that you can ablate in real time using a small cryo machine, superficial, breast tumors. This is started ablating fibroadenomas. This is done under local anesthesia in the surgeon's office. And it has been shown to be successful for very nicely ablating, about a 20-minute procedure, no hospitalization. And the ablation technologies, you can also robotize, and this is a system that can actually, you can target it to a certain point, and the robot drives the needle to the target that you point to. Another system that allows the surgeon to accurately target a deep point in the patient's body without hitting other targets on the way, like blood vessels or nerves. So a combination of ablation technology, flexible endoscopy, reaching deep places in the human body would probably replace in the next, I think, within 5 to 10 years, we'll start replacing surgery. And if you look around you see that this is actually happening. Like Professor Chu, people removing early tumors in the colon, in the stomach. People are ablating liver tumors instead of removing them, with results that are improving all the time and will probably surpass surgery quite quickly. This is a system that ablates a prostate tumor using a system, transrectal ultrasonic system, that has both scanning capabilities and ablation using focused ultrasound. This thing, for instance, can replace robotic prostatectomy, which is a mutilating, difficult operation. You can ablate patients within the MRI machine, ablate breast tumor using focused ultrasound without even penetrating the skin, what I call non-invasive surgery. So towards the conclusion, where we are now, there are electromechanical systems, there are assisted systems, there are semi-autonomous and fully autonomous, and they can all be in furniture, in bed-mounted system, in handheld systems, endoluminal and directed energy. And we can move forwards within all these platforms towards assisted or semi-autonomous systems. And this will actually integrate surgery and image-guided intervention into one profession. And we have to get ready and think of how we build hospitals and how we build clinics around this concept. And the questions remain is how do we credential surgeons to do ablation? How do we credential gastroenterologists to do what is actually surgery? How do we train people and mix these professions to work together? And how we compare different platforms, robotic platforms to each other in terms of patient outcome, times and complication. So these are my conclusions. I think it's going to be very interesting. There's going to be a lot of competition. There's going to be a very big spectrum of systems to choose from. And I think we have to be very careful in selecting which technology to adopt, because our responsibility is not only to our patients, but to society as a whole. And I think we cannot drain the society's resources using extremely expensive systems. And this is actually a zero-sum game. This money has, if it's going to buy a $2 million robot, it's going away from something else. So I think we should focus on value, cost effectiveness, and the ethics of what we do. Thank you very much.
Thank you, Amir. We have 3 very interesting lectures. I think we have time for 1 or 2 or 1 questions each. Do you have any questions from Ray?
Good afternoon, everyone. Hi, Philip. I was tasked by Alan to ask you a question. Well, as you, it's a very interesting lecture, and you presented the flexible robot that goes through the lumen and then do some endoscopic surgeries, right? Now, Notes has been sidetracked a little bit, and do you see in the near future that these flexible robots might be able to revive Notes or transluminal or transluminal surgery inside areas or abdomen?
Okay, good question. Actually, I think we have explored the possibility of using the flexible platform to try pass within the peritoneal cavity into different area. We can access those, but in order to perform some procedure, it's kind of very difficult because flexibility takes away the dexterity of your scope and the manipulator and the instrumentation. So I think in the future or currently, our concept of endoluminal surgical intervention and the first space endoscopy is to do something adjacent to the GI tract. So thinking that the GI tract is one of the pathway to reach the target, you can do something adjacent to that GI tract. So maybe not through the peritoneal cavity, but I think the GI tract can reach a lot of the space, and probably, for example, like you can see EUS guided gallbladder drainage, you have seen endoscopic full thickness resection. So those are nice developments from the concept. So even with the flexible robotics, we don't have the dexterity to reach to perform something like cholecystectomy. I think at the present moment to win over laparoscopic cholecystectomy.
Thank you, Philip. Dr. Allen, can I ask another question?
Yes, please.
Okay. I'd like to direct the questions to Professor Zog, Philip, and the rest of the panel. It was mentioned earlier by Professor Amir that there is a trend wherein flexible endoscopy, which is usually done by our GI colleagues, would have to do certain procedures that are beyond the the credentialing of a gastroenterologist, or they're actually performing surgeries already. Do you think that there will be an evolution of the doctor or the physician becoming a not a surgeon, not a gastroenterologist, but a digestive disease surgeon, like what has Peter Cotton envisioned many, many years ago, that there's a physician, a doctor trained to do surgery and do actually gastroenterological work?
Well, I think that that's an excellent question, and I think that we are being misled by the tool. You know, gastroenterologists did not perform endoscopy in the past. Surgeons performed endoscopy. Most of the innovations in flexible endoscopy were made by surgeons. ERCP, polypectomy, POEM, you name it. Almost everything that was invented in what we call surgical endoscopy was invented by surgeons. And I think we somehow abandoned it, mostly because we were so excited by laparoscopy about 30 years ago. And we need to get back to this tool as part of a surgical toolkit. I mean, I went to learn flexible endoscopy when I was 60, just some years ago. And I now incorporate it completely into my practice. I don't do any upper GI procedures without performing intraoperative endoscopy. And I started doing all kinds of things during this, and that's completely transformed my practice. And I'm really late in my career. And I think we should all adopt this, and we should push our residents to go and learn it. And we should do the political parts. In Israel, we had a 10-year fight with the Union of the Gastroenterologists until we made flexible endoscopy part of the surgical training, and that you can rotate through gastroenterology and your gastroenterologist can rotate through surgery. This is a big change because we are used, I mean, the structure of a hospital, of how we work, was determined about 100 years ago, and it hardly has changed. We've just grown the same. So we need to restructure the way we work. So one of the ways to do it is to start a department of gastrointestinal diseases and work side by side, and then people will slowly merge and learn how to use all these things together. That's another option. But I think we must do it, and we also must use at least imaging devices that are, that could be taken by hand, like an ultrasound machine. We have to learn how to use these things and incorporate it into our practice, because ablation technology is based on imaging, and we cannot allow all these things to completely trickle away from surgery, because we will remain with hernias and trauma.
Thank you very much. It's very enlightening, and I think it will inspire future surgeons or even the boards of PALES to change the curriculum in terms of merging endoscopy and laparoscopic surgery as the main spirit or the spirit behind minimally invasive surgery. Philip, yeah.
I have just one comment for all the surgeons. Please pick up your flexible endoscopy. Please, this only comment I have. I saw the development. I am in the development. Please pick up your flexible endoscopy.
Very true. Thank you, Philip. Thank you, Amir. I think Don has a question for Andrea.
Hello, Professor. Good afternoon again. Thank you for your lecture. And I think it's one of the very integral part of doing surgery is to do it first, especially for tricky cases, to do it first in a model rather than going straight forward to the patient. I would like to ask, however, has the 3D printing during any procedure decreased the learning curve of surgeons where you are at?
Thank you, Don, for this question. I cannot answer to that now because we are in the process of running, as I mentioned, this pilot study on kidney transplantation. But I would be surprised if that would not be the case. And I think it is evident to anyone that if you can practice on a physical model, which is more or less well, let's say very extremely similar to the real situation, and a model which is patient specific, I think there's an evident benefit for the trainees. The only thing that might represent a problem perhaps is the cost of such a model when you need to train a significant number of people at the same time. But again, that's not the case for kidney transplantation. Our need was to train a couple of new fellows, and the extra cost per case is less than $300. So is acceptable, I think, if we take into account the benefit of the whole thing. But again, I'm trying to explore new avenues and potential use of 3D printing technology. And it's amazing how the landscape changes so quickly. So we have start with an idea of simply surgical planning, and we ended up producing new tools for cardiologists and new training systems for nurses and many other things that I skipped today. So the technology is not here for one reason or for one target. It's a technology that can be used. You know, the only limit is your fantasy to devise new scenarios. But as my friend Philip was saying for endoscopy, please embrace 3D printing in your hospitals, and you like it, you love it.
Thank you. As always, love asking me questions.
Thank you. Thank you. I think we ran out of time. So I would like to take this opportunity in behalf of Dr. Tan, our president, and of course, the board of directors of the Philippine Association of Laparoscopic and Endoscopic Surgeons. We would like to thank Andrea, Amir, and of course, Philip for joining us and for giving us the patience for coming in and then sharing us your time and your expertise. Thank you so much. Maraming salamat po.
Thank you very much.
Thank you, Amir. Andrea, thank you so much. Philip.
Thank you. Thank you.
Thank you so much. Anyway, we go to the next session. Our next session is about, let me see the program now. Okay. Our next program will be about the hernia and beyond. We've seen a lot of interest on abdominal wall repairs. So we saw it fit to invite two experts in abdominal wall repair. One from India, a very good friend again of mine, Professor Anil Sharma, and Professor Victor Radu from Bucharest, Romania. Two of which these two experts are well known and well regarded in the field of hernia surgery. Co-moderating for me in this session is another pillar for hernia surgery in the Philippines, Dr. Henry Chua from Cebu. Henry, please come in. Henry? Hello.
Hello,
Henry. Are you okay? Are you in?
Alan?
Yes, Henry, you can go.
Hi.
Yes,
Good afternoon.
Good afternoon, Henry. Okay, Henry
Good
will
afternoon, Alan.
introduce our two speakers for today. Henry.
Yes. And we have okay. Okay, good afternoon. I hope you can hear me well. My signal is not too good here. Greetings from Cebu, where the world's longest city COVID-19 lockdown is still currently running. As early as now, I would like to congratulate Dr. Jeff Domino and the rest of the organizing committee for preparing this robust program for all of us in the midst of this pandemic. Thank you, guys. It is my honor to co-moderate this session on hernia and beyond with no less than the Philippine Hernia Society President, Dr. Alan Buenafe. It is likewise my privilege to introduce our very distinguished panel speakers for this session. First off is talking on the topic of ETEP. He's the director for endohernia surgery at the Max Institute of Laparoscopic, Endoscopic, and Bariatric Surgery, Max Healthcare. He's the president, a former president, and a founding member of the Asia Pacific Hernia Society. He's a director of the Hernia Essentials Training Program of the APHS. He's an examiner and overseas clinical tutor of the Royal College of Surgeons of Edinburgh. He's an examiner of the Royal College of Surgeons of England. And he's an editor of the Journal of Minimal Access Surgery. He's a section editor of Hernia Journal and EXICOM member of the Indian Association of Gastrointestinal Endosurgeons. He's an accredited faculty and examiner for the National Board of Examiners in India, and a founder and director of the Basic Medical Writing Course for Surgeon. It's my honor to introduce my good friend, Professor Anil Sharma. Anil.
Hi.
Hello, Anil.
Well, hi. Thank you, Henry, and
You're very welcome.
Thank you. Well, thank you for the kind introduction to be speaking here today. I just want to say that I'm very happy, very honored to be addressing you, in your prestigious annual Congress of the PALES. I wish I were in Cebu, well, Henry, but I've got to make do with being in New Delhi at the moment. But I have visited Philippines a number of times, and I have, in fact, always carried back very fond memories of having good fun, good laughter, but then most of all, great and lasting friendships. So I hope that sort of tradition continues in the future. My job here is to speak on ETEP. And so well, right up, I have no disclosures to make for this talk. There seems to be a renewed interest in looking at the alternatives that laparoscopic surgeons have for the surgical treatment of ventral incisional wall hernias. Okay, let me share my screen first of all. You got to let me know, Henry, if you can see my screen.
Yes, I can. Can you put on the slideshow mode, please?
Yeah.
Okay, there it is. That is good, Anil.
Okay, got it, Henry?
Yes.
Thank you.
You're welcome.
So we all know that the position of the mesh for a hernia repair could be onlay, which is on top of the anterior rectus sheath. It could be inlay, which is like a bridge between the two recti muscles. Could be retrorectus or retromuscular, which is behind the rectus muscles and in front of the posterior rectus sheath. Could be pre-peritoneal between the posterior rectus sheath and the peritoneum, and finally intraperitoneal. So the retrorectus space is the same as the ETEP space, and the advantage of staying in this space is that you can repair a wide variety of both inguinal hernias and ventral incisional hernias of the abdominal wall as well. So by staying in this retrorectus space, you can repair small to moderate sized paraumbilical hernias, epigastric hernias as shown, much in the manner of a Reeve stopper repair. For the larger and more complex hernias, this space can be extended laterally to the lateral compartment of the abdominal wall, and by in fact dividing the transversus abdominis muscle. And I'm sure our friend well, Victor would be in fact speaking to us about this next. The retrorectus space superiorly becomes contiguous with the pre-peritoneal space below the arcuate line, and by making the first port of access 4 to 5 centimeters above and lateral to the umbilicus, one can get a much wider exposure and a much larger surgical field to tackle the large hernias of the groin, the complex hernias of the groin. By incising the lowermost aponeurotic fibers of the transversus abdominis muscle in the lower abdomen, one can access the pre-transversalis space, and the pre-transversalis space would be in turn contiguous with the retroperitoneal
Anil,
space.
I'm sorry for interrupting. Your PowerPoint is not moving.
Oh, my PowerPoint is not moving?
Yes. Who's controlling your PowerPoint?
Me.
It's not moving. We can see your slide, but it's not moving.
Okay. So
Thank you.
should I?
Okay.
Can you share it again?
Yeah, share it again.
All right.
Thank you, Neil.
Then click the slideshow button.
Okay. Should I move again with the slide then?
Yes.
Does it
And then
move?
kindly press the
Slideshow button.
the slide for play. It's on your
Does it move?
right lower. Can you see it?
Okay, approve. So the slideshow for me, please, again. So somebody has taken control, Alan, to run my slides, and I have granted permission. So can I go to the slideshow, please?
I think the slideshow is not working.
Okay.
The one on the lowermost, right lowermost, Anil. You have the comments, and right, and then go to slideshow.
Yeah, that's what I did, Alan.
Yeah, okay.
In fact, control is not with me at the moment. Control has been taken over by the admin. So,
Doc, I'm controlling it right now, but the slideshow is not
yes.
working. I think there's a problem with the file.
Okay, should I try another?
Yes, please.
Should I try another presentation? Does it move?
Yes, it's not moving.
Does it move?
I think you can click the slides on the left side.
All right then. Okay, I'll do that.
I will
Okay, let me do
transfer you
that.
there.
Okay, so this slide is just to show you that once you are in the pre-transversalis space, you can go right down to the retroperitoneum, just beside the psoas muscles. So the approach to the retromuscular space, this is the shaded area that perhaps some of you can see behind the rectus muscle and in front of the posterior rectus sheath. The neurovascular bundles actually perforate the posterior rectus sheath laterally, and that is an area you've got to be careful when you are dissecting there. So the approach to the retromuscular space can be laparoscopic, and to show this, I will need to go back to the slide screen because only then the video would work. Oh, dear me. Can you get the video, Henry?
The
Can you
video
see
is
the
not
video,
running.
Alan? Right, okay. So this is just in fact one of the accesses that is possible to the retrorectus space. This was like a Fannin steel incision on the peritoneum down in the pelvis. So one is in fact looking from the left and then working from the bottom. This is one possible approach to the retrorectus space. And we used to use this approach when we in fact performed the linear stapled anastomosis for small midline ventral hernias some years ago. The same procedure can be done from the left side as well, instead of doing it from the bottom. And that is what some surgeons do in the TARM procedure, the so-called transabdominal retromuscular procedure. The alternative access to the retromuscular space could be from percutaneously, from, by in fact dividing the skin, the subcutaneous, and then going down to the anterior rectus sheath, incising the anterior rectus sheath transversely, taking control with stay sutures on both lips of the anterior rectus sheath, and then splitting the rectus muscle to gain access to the retrorectus space. So with the finger, one makes a little space initially, and then this is an indigenous balloon that we use to make the space initially. And then this is the Hassan trocar. And the first view from the inside. So this is being used for repair of a large complex groin hernia. And you can see that with this sort of an approach, you have a much wider surgical view, and you have more operating space, better ergonomics. The third possible option for an access to the retromuscular space is with the Mylos technique, which is quite popular in Germany. This is a transhernial approach to get into the same retromuscular space that we are talking about. These are just a few steps of an ETP repair for a small para-umbilical hernia with divarication of the recti. So you can see the telescope on the left side, the surgeon's right-hand port on the left flank again. This is space being created in the left flank again for the surgeon's left-hand port. Let me see if I can move this a bit forward. I can. But this is still, in fact, working down in the pelvis and trying to make the space down in the pelvis. This is now, in fact, looking up, looking up from a port in the lower left flank. This is a division of the same-sided posterior rectus sheath. So you can see once that is divided, you in fact encounter some fat. And this is the area to be a little careful to find the right plane to get into the contralateral retrorectus space. Now that is the posterior rectus sheath of the contralateral side, which is being divided to gain access to the contralateral retrorectus space. So again, making the space some more. I'll try and make up for some lost time with this video. So what this is in fact working down towards the pelvis now, going towards the pelvis, and we will soon enough see the hernia. That is the first view of the hernia. The advantage of the ETP approach is that you can reduce the entire hernial sac along with the hernia, and this should lead to a lower
Hello, Anil.
No, sorry. I think he's disconnected po, Doc.
Oh my. Anyway, I think we just need to move on. Let's just wait for Anil. Let's go on to the next lecturer. Henry, are you there, Henry?
Yes, Alan.
Yeah. Can we go and move to the next lecturer? Let's call on Professor Victor Radu. And then I'll get back with Anil. I'll call Anil on the phone and try to fix the presentation of Anil. Let's go first to Professor Victor Radu.
Good afternoon once again. Sorry for the technical difficulty. Let's proceed to the second lecture for this afternoon. It will be on CAR, and our speaker is a master surgeon in hernia surgery, accredited by the Surgical Review Corporation, USA. He's the director for the Center of Excellence in Hernia Surgery, MedLife in Bucharest, Romania. He's a trainer for the European certificate. Friends, let us welcome Professor Victor Radu from Romania.
Hello and good afternoon, everybody.
Good afternoon.
It's a great honor for me to be invited to PALES Congress. Thank you for the invitation. Now let me share my screen. Do you see my screen?
Yes.
Okay. So I would like to present to you quite a new technique in ventral hernia repair. It's about ETEP and ETEP-TARD. Professor Anil started to present this technique. Unfortunately, because of technical reasons, I am the first who tried to present this technique. So my disclosure. This technique was published 4 years ago by Dr. Igor Belyansky from United States as a paradigm-changing technique. By closure of the defect, place the mesh outside of the abdominal cavity and minimizing mesh fixation. We can fix, using this technique, primary ventral hernias and also incisional and even complex incisional hernias with multiple sites defects. The contraindications of the technique are related to mesh infection, enterocutaneous fistula, or relative contraindications as loss of domain or dystrophic and ulcerated skin. The principles of this technique can be realized connecting three spaces. It's about the preperitoneal space represented in the upper part of the abdomen by the umbilical ligament, in the lower part of the abdomen, falciform ligament is up, and umbilical ligament is in the lower part of the abdomen. The retrorectus spaces, and laterally to the semilunaris lines, the pretransversalis space. To connect these spaces, we have to cross over the midline. So if the hernia is located in the lower part of the abdomen, I will cross over the midline from above, in front of the falciform ligament. For that, I develop the left retrorectus space. I cut the medial aspects of the posterior rectus sheath. I cross over the midline in front of the falciform ligament towards the right retrorectus space. If the hernia is located in the upper part of the abdomen, the crossing over of the midline will be done from below, in front of the umbilical ligament, as you can see here, to connect the both retrorectus spaces. Position of the patient is very important. As you can see here, the table is flexed. In this position, we can optimize the ports placement. The ports are placed in a different way than in IPOM. In IPOM, we used to place the ports as laterally as possible, in fact, on the anterior axillary line. In ETEP access, we will place the ports medially to the semilunaris lines in the opposite part of the abdomen to the hernia location. Now let me show you the key stages of the procedure. This is a patient with a hernia located in the lower part of the abdomen. I'm a right-handed surgeon, so I sit on the left of the patient, and I start to develop the left retrorectus space using an optic port. You can see here the left rectus muscle, posterior rectus sheath, laterally is linea semilunaris, and the neurovascular bundles. Next step is place the second and third port under direct vision. Now, I start to cross over the midline. I cut the medial aspect of the posterior rectus sheath on the left. You can see here the fat of the falciform ligament, which remains on the floor. Linea alba is up, and it is very important to identify the posterior rectus sheath on the contralateral part where we have to place the incision to maintain the integrity of linea alba. So I cut the posterior rectus sheath on the left, and I start to develop the contralateral retrorectus space. We get this anatomy: left rectus muscle, linea alba, on the floor is falciform ligament, and right rectus muscle is here. Next step is that I place another port under the right costal margin for the scope, and I change my position. I start to dissect in caudal dissection, cutting the medial aspects of the posterior rectus sheath, which become the edges of the defect. As you can see here, the volcano sign, I start to reduce the hernia, gentle to avoid injury of the content of the hernia. Here we are into the peritoneal cavity, and you will see very soon a small tear of serosa, but I would like to highlight that the risk to injure the viscerae into the sac is not higher than the risk in IPOM, because now we are into the peritoneal cavity. After I reduce the hernia, the next step is measurement of the defect. If the defect is too large to be closed, or the width of the defect closely approximates or exceeds 2 times rectus width, TAR is needed. To perform a TAR, being a right-handed surgeon, I start to perform TAR on the right side. So I sit on the left of the patient. I place my camera under the left costal margin and I work from the left. First, I identify the neurovascular bundles. As you can see here, this is the posterior rectus sheath on the right. Why? Because I place my TAR cut line medially to the nerves to protect them. I cut first the posterior lamella of the internal oblique muscle. Always I pass the linea arcuata caudally. Then I start to cut the muscular belly of the transversus abdominis. And I extend my dissection as laterally as possible and as cranially as I need, depending on hernia location. What I would like to highlight is that the transversus abdominis and the diaphragm are situated on the same anatomical plane. The limit between these muscles is represented by a thin fatty tissue, this yellow line, which is a very constant landmark between the transversus and the diaphragm. It is very important to carve medially on the top our TAR cut line to avoid damaging the diaphragm and also to connect this space to the contralateral space behind the xiphoid process. To perform TAR on the left, being a right-handed surgeon, I start from the bottom. I dissect the fat into the Bogor space, I dig a cave behind the fascia, and then I respect the same steps as I described already on the right. Of course, after I perform my TAR, I continue my dissection, retromuscular dissection, as laterally and as cranially as possible. Next step is closure of the defect. Usually I start closing the posterior layer. I use resorbable barbed suture, and it is very important to avoid any tension in the suture line. Next, I start to reconstruct linea alba. I'm much more confident using unresorbable barbed suture, and always I hang with my needle the peritoneal sac to avoid dead spaces and postoperative seroma formation. In the end, I place the mesh. I use large macroporous polypropylene mesh without any fixation and usually without drains. If the hernia is located in the upper part of the abdomen, I sit on the right of the patient and I start to develop the right retrorectus space. This is the right rectus muscle, right posterior rectus sheath, linea semilunaris on the right, neurovascular bundles. I place my ports under direct vision medially to the linea semilunaris, as you can see here, at the level of linea arcuata, protecting the integrity of the vessel. So, being a hernia located in the upper part of the abdomen, I cross over the midline from below the umbilicus, cutting the fat of the umbilical ligament. Here is the umbilical ligament, here is linea alba, right rectus muscle, left rectus muscle, and here is retio space. Now I place another port here on the left lower quadrant for the scope, and I change my position, continuing dissection retromuscular from caudal to cranial. So I reduce the hernia, this is the hernia, and I cut the medial aspects of the posterior rectus sheath towards the xiphoid process. Next step is closure of the defect in the posterior layer, restoration of linea alba using unresorbable barbed suture, I hang the peritoneal sac to avoid dead space and postoperative seroma. And in the end, mesh placement. Let's talk about complications. I mentioned that it's very important to avoid any tension in the suture line when we close the posterior layer. Look at this patient. I close the defect quite easily. You can see that the edges could approximate easily, but there is some tension in the suture line. Even though I could approximate the edges of the defect. So what happened? On the following day from the surgery, the patient developed a small bowel obstruction. I reoperated on him and I found this rupture in my suture line. My operation was laparoscopically. I reduced the bowel, and my solution was to change direction of my suture line on the posterior layer to decrease the tension in this layer. If this solution is not enough, TAR is needed. This is a retromuscular hematoma occurred after 2 weeks from the surgery. It is a patient under anticoagulant therapy because of cardiovascular disease. In this situation, I evacuated the hematoma and I placed the drain. And this is a recurrence. Occurred after 1 year from the surgery. You will see the defect is located superior to the mesh. For sure, it was a small injury of linea alba when I crossed it over, unobserved injury, which due to this recurrence. So it is very important to be sure that you maintain the integrity of linea alba when you cross it over, or every injury must be closed and covered with mesh. Here you can see a couple cosmetic and functional aspects pre and post-operatively. All my patients are monitored. This patient is on follow-up after 1 year and 2 years. I lost from follow-up just 2 patients, and until now, no chronic pain was reported, 1 recurrence, the mean of hospitalization less than 1 day. About complications already discussed. So a couple of take-home messages. First, and I think the most important, is understanding the anatomy. About TAR, it is very important to identify the neurovascular fibers, to perform TAR medially to the nerves, encephalon dissection curve, the TAR cut line to connect to subxiphoid space, and always caudally past linea arcuata to release the fascial flap. And in the end, the advice, at least on the beginning, because this technique is quite challenging, it's a must to be mentored to get good results. Thank you.
Thank you, Victor, for a very nice lecture. I think Anil is ready. Anil, are you ready with your lecture? Anil? Anil, I think you're on mute. You can press the unmute button. It's on the lower left. We'll have the open forum after the lecture of Anil, and we can ask all the questions for Victor and Daniel. I know there's a lot of interest in abdominal wall repairs nowadays, and these are the 2 most interesting topics right now in the world of hernia surgery. Are you okay, Anil?
Yeah, I'm just trying to go past the video and come to the slides.
Thank you.
Can you see my slide?
Not yet, Anil.
Okay,
share screen.
Right. Okay. So okay, you got something now, Alan?
Yes, we can see your screen now. Can you press
all right.
on slide share? Start
Yes,
the
that's
slideshow.
slideshow.
Perfect, that one.
Okay, you got it?
Not yet.
Oh, you don't get my slide?
We have your slide, but it's not on slideshow.
My goodness.
Can you press again? I saw your arrow actually on the slideshow.
Can you get it, Alan?
No.
Oh,
Can
all
you?
right, then let me just try and show it to you from a different. Now can you get it?
We can see the slide actually, but it's on, not on the slideshow.
No, so it's okay as long as you can see it, Alan. I can speak. I really don't understand, what went wrong here, but my apologies. And we've just seen a very excellent demonstration of the ETP technique by Victor, and he's shown us, the entire steps of the procedure so well. So what I will do is I will just speak about 2 or 3 things that come to my mind, about this technique vis-a-vis the good old IPOM.
Okay.
So for all practical purposes now, we as laparoscopic surgeons, do have a choice when we are faced with, say, midline hernias between 2 and 8 centimeters. And the choice stays essentially between an IPOM repair and now a retrorectus or an ETP repair. So the main issue here is the big advantage of the ETP repair, of course, is the fact that you can place an extraperitoneal mesh. That is the main reason that we are, seeing renewed interest in this procedure. But then talking about the intraperitoneal mesh, conceptually, it doesn't seem to be right because you have a mesh that is in close proximity to the viscera. But then this is one study that I like to quote because this is a population-based study, and this says, this in fact has looked at patients for a period of 5 years. And this tells us that the cumulative incidence of mesh-related complications with laparoscopic repairs is much lower when compared to the open repairs. And this in fact mainly talks of the IPOM repairs. And these are population-based studies, which means that they are talking about real life scenarios more. So we're coming back to the laparoscopic IPOM repair. The advantages, of course, are that it is minimally invasive. There is no collateral damage. It can be done fairly easily. It is readily reproducible, and we have long-term results available. But the advantage of the ETP repair, of course, is the fact that you can use a basic mesh. You don't need a coated mesh, so that in fact reduces the cost of the procedure, which is a very big advantage. There is less fixation required, like we saw Victor, telling us that you don't need much fixation in that retrorectus space at all. So I think less the penetrating fixation, the less is going to be the pain for the patient. And we can see that in our patients, in most of the patients with an ETP repair, the pain factor is low. The advantage of an ETP repair, again, is the fact that the retrorectus space can be extended to the lateral compartment of the abdominal wall by dividing the transversus abdominis muscle, just like Victor showed us. So the downside of the ETPV procedure, of course, is the fact that though it is minimal access, there is maximal invasion because there are new tissue planes that are created. Large tissue planes need to be created. But then mainly there is collateral damage that comes with the procedure because the posterior rectus sheath of both sides needs to be divided so that you can in fact prepare the space for the retrorectus mesh so that you can prepare the landing zone for the retrorectus mesh. It is, of course, technically more difficult, and we still have to have long-term results, with the ETP repair. So I tried to put down some of my thoughts in an editorial in the Hernia Journal, which has just been published, I think, 2 or 3 weeks ago. And what I wanted to say, in fact, was the fact that there is no doubt that the endolaparoscopic repairs, such as the ETP repair, is a great advance. But this is an advance that comes with an inherent morbidity because of the extensive dissection, and then more importantly, the posterior rectus sheath that needs to be divided on both sides so that you can make the space for the mesh. Therefore, I believe that there is a need to rationalize the indications for these endolaparoscopic retromuscular mesh repairs. And to my mind, the larger midline hernias, multiple midline hernial defects, symptomatic divarication of recti, recurrent hernias following a previous anterior repair are some of the indications that I believe would be just for an ETP repair. The guidelines from last year from the International Endohernia Society, talk about several new procedures that have gained currency, mainly in an attempt to place the mesh in an extraperitoneal location. This is a list of those procedures, and the essential take-home message from the guidelines is that we have several case series like the one that Victor Radu was associated with that say that yes, we have good short-term outcomes, but we are still waiting for a medium to long-term outcomes with this procedure. And of course, since this is technically difficult, it should not be attempted without adequate training. So my point is that when we talk about hernia, we talk about a benign, non-life-threatening condition most of the time. So we must try and not be too radical with our surgical procedures. There is a saying that says less is more in hernia repair, which means that if you can get the same results with a lesser repair, you must think of the lesser repair as well. The primary reconstruction of the midline and closure of the hernial defects for all patients may not be required. That is a good goal to have, but then in some patients, you do need to make exceptions. And finally, of all, my parting message is that first of all, as surgeons, we have to be certain, we have to be careful to do no harm. Thank you for your attention.
Thank you so much, Anil. Yeah. It's a very interesting concept of on abdominal wall repairs, and it creates a lot of interest among surgeons who are interested in doing abdominal wall repairs, especially for the last few years, where the concept of TAR, stopper ribs, and everything, all the alphabet soup on hernia repair. And there's a lot of, well, we're supposed to have a debate supposedly, but then again, we opted on having a report, a sort of a lecture coming from both sides, coming from you and coming from Victor. I would like to invite that. I think we have a lot of panelists here that are quite so interested in hernia surgery. We have Ken Loy from Australia, who was also one of the uh, surgeons who's doing a lot of hernia surgeries, and Andreas Shami. Hi, Ken. Welcome. Uh, I would like to start off with a question to both of you, to Victor and Anil. For I know both of you are doing TARs, Reeves Topa. Choosing between for a smaller hernia, the first question would be, how would you classify now your hernia as a small one, abdominal wall hernia, as a small one wherein you can do your IPOM or your interperitoneal, we call it interperitoneal mesh repair now. And when would you start doing for a stopper ribs or a retrorectus approach for your patient? So is IPO, interperitoneal mesh placement, still have a place in your practice? So question for both of you, Anil and Victor.
Anil, please.
Okay. Okay. Thanks, Victor. Okay. Well, my response to this is, Alan. It is not just the size of the hernia diameter that is, finally that in fact makes you decide about what procedure to do. Like it is a combination of many factors like size of the defect, the tone of the abdominal muscles, the shape of the abdomen, the BMI, the surgical ergonomics that go along with the patient. But then by and large, for me, a small hernia would mean less than about 3 centimeters or so in size. So for me, something that is less than 3 centimeters in size, but still needs a surgical repair, would not qualify for an ETP repair. And the hernias normally between 3 and 6 or 7 centimeters or so would be candidates for an IPOM repair. But then they were larger hernias, like I in fact showed you that slide where we believe ETP repairs, are really useful, are when you have multiple hernial defects in the midline, when you have a hernial defect with a divarication of the recti that needs to be addressed, and when when you have, say, larger hernial defects, and by that I mean more than about 6 centimeters or so. That is, for me, a sort of good indication for an ETP repair. And by and large, hernias between 2 and 6 centimeters or so, my go-to procedure would be an IPOM at the moment.
Thank you, Anil. How about you, Victor?
So first, I'd like to say that I totally agree with Anil regarding the overkill. So my concern is not overkill the tissue for small hernias first. Then I use the EHS classification in my practice. And about the procedures regarding this avoiding of overkill. If it is possible to fix small hernias and not touch the retromuscular space, because I consider the retromuscular space as a holy space. It's a brilliant space, and should be preserved for specific disease. So my first option for small hernias is TAP, is transabdominal preperitoneal repair. For medium or small or medium ventral hernia, especially on skinny patients when the preperitoneal fat is quite absent and the preperitoneal dissection is difficult, yes, I do a retromuscular approach, but in a different approach to do not overkill. For example, for an umbilical or supraumbilical hernia, yes, it is an overkill to cross over the midline behind the xiphoid and dissect the entire retromuscular space. So I start a little bit different and I dissect just the area where I place my mesh, respecting the overlapping criteria. I posted this modification on EHS Facebook page. And about IPOM, I consider, so first I leave IPOM on my back for 4 years, but I think IPOM, it's a good procedure. It demonstrates for a couple of decades, and I don't want to kill IPOM. I preserve IPOM for specific cases. For example, if the patient develop a recurrence and the retromuscular space is already used, yes, this is an indication for IPOM, for example. Thank you.
Thank you, Victor. Let me borrow Ken Loy. Ken is a upper GI surgeon, a bariatric surgeon, also having an interest in doing hernia surgery. He's our speaker for the trauma one, for the trauma session, but he's so interested in abdominal wall repair. Did it change your outlook on how you do your abdominal wall repairs, Ken, with the development of all of these things in the past few years?
Thank you, Albert. Be honored to listen to two big speakers speaking about the technique. I guess the only thing is I'm still doing mostly IPOM, but for the bigger hernia size, I resorted to open. But looking at Victor's technique, definitely it's worthwhile trying laparoscopic. The only question that I want to ask Victor is what sort of abdominal pressures that you are running? Because I guess most of you will probably be wondering, when you inflate the abdomen, there will be under tension and it will make laparoscopic suturing very difficult. And certainly with that needle, you don't want to get anything underneath, but you also want to not lacerate the momentum and then have recurrence, etc. So I believe controlling of the abdominal wall relaxation and tension may be important in your technique. Just want to get your view. Maybe I can start venturing out there.
Yes, it's a very, very important condition to work under very relaxed abdominal wall. So you must be very close friend with the anesthesiologist for that. Okay, so I used to work under 15 millimeter mercury pressure, but when I start to close the defect, first I place my suture, and when I tie it, I drop off the pressure down to 5-6 millimeter mercury to can approximate the defect. I like to create the similar condition as in physiological condition.
Very good. I think that's the very important trick. I can see your suturing skill was excellent. And, you know, and the way that you don't pull, because a lot of beginners, they will start pulling the moment they're suturing. which will create a lot of tension and break the rectus muscle. So you actually loosely place it and you drop the pressure and you tie it. I believe that's probably the key to make this procedure successful. Plus you would have judged how much you need to release on the side, which is important. The best thing, I agree with you, no suture fixation, because it will just increase the stickiness of the mesh. But I think any mesh can be done.
Yeah.
Thank you, Ken. Thank you, Victor, and thank you, Anil. In behalf of our president, Dr. Boy Tan, and the board of directors of the Philippine Association of Laparoscopic Endoscopic Surgeons, I would like to thank both of you, Victor, Radu from Bucharest, Romania, an expert in abdominal wall repair, and of course, one of our pillars in Asia Pacific Hernia Society, Professor Anil Sharma, for joining us and sharing your expertise and your time to us. Henry, any last words? Henry Chua? I think Henry is having
Hello.
some difficulties with his connection. Henry?
Yes, Alan. Thank you very much, Professor Sharma and Professor Radu. Those are excellent lectures from both of you.
Thank you. I think we need to go on and move on to the next session. Our next session, I think this is the last session for this afternoon's program. Dr. Roel Azores will be moderating this with me. The session is about facing minimally invasive surgical emergencies. And we have two distinguished gentlemen, invited gentlemen as our guest speakers. One from Linz, Austria, and the other one from Australia, from Sydney, Australia. Let me call on Dr. Roel Azores to introduce our two good friends from Austria and from Australia. Roel?
Yeah, hi Alan. Yeah, good afternoon everyone. I'd like to give an introduction of the two speakers since the start of COVID. This COVID pandemic, I'd like to tell everyone as the impact of COVID-19 on the surgical practice has been widespread, no? Ranging from the workforce, staffing issues, procedural prioritization, viral transmission, risks intraoperatively, changes to the perioperative practice, and even impact on the surgical education and training. This afternoon, we'll be discussing the most common issues in laparoscopic surgery during this pandemic. One issue is the aerosol transmission procedure, the role of laparoscopy in emergencies procedure. Do we open or do we do lap? So we have invited two speakers to give you an introduction of our first speaker. He's the regional chairman of NSW RACS, the secretary treasurer of IPSO APC director, the consultant of St. George Public and Private Hospital, the consultant Karen Private Hospital, is also the consultant of Sutherland Public Hospital and Kingsway Day Surgery. He is the advisor of Department of Health and Aging. Colleagues, let's welcome Dr. Ken Loy, MD, to talk on the
Perhaps I will say that I think it's actually my honor to able to share with our Philippine colleagues and over the world about what we're doing in Australia. I was going to tease Alan and say, how can we put Austrian and Australian together? They are actually totally separate, different continent, but a lot of people do get us mixed up. So Australian is the place with kangaroo, and Austrian is the place with sausage and wiener. So it's very important to distinguish that. But I think this is a very light-hearted lecture. A lot of the experience, I think you can look at it on the web, and I'm sure a lot of people, a lot of surgeons now are very concerned about it. So I'm actually also here to learn, and I'm happy to be corrected as well. But I'll share what we've been doing in Australia for you. Now, if you can hear me properly, I'll start sharing my screen. Now, now I will, apparently there's privacy issue, so it's okay. I will log back in right away.
I think Ken Loy is logging in again
Yeah.
for this one. While waiting for Roel,
Yeah.
move first to Professor Shamiye. Andreas,
Okay.
in the interest of time, yeah, let's just move for.
Yes, I'm here. I'm here.
Will, yeah.
Can you hear me?
Yes, we can hear
Yes,
you.
Professor.
Should I
back.
start the presentation? No.
Oh, Ken, are you okay?
I'm back. I'm sorry. Just now, I got my new computer, so I have to start sharing my PowerPoint now.
Okay, sorry, Andreas.
Sorry about that. I'll make sure I won't overrun it.
It's okay.
So I guess a lot of people initially was quite jealous about Australia. When I first gave the talk about probably a month ago, I was telling people that a lot of my colleagues want to come to Australia, and the only way they can come to Australia is either by swimming, or and if they don't get killed by sharks or the crocodiles, then they can come to Australia, because we've been doing quite well to control our caseload. We've gone from peak of almost 400-500 patients per day down to almost virtually, now about, sort of 10-15 patients a day, which is manageable for a country like us of about 30 million people. But recently, it only takes a few people in Melbourne that coming from overseas and infected other people. We see our caseload going, and I believe it's like that in different countries as well. So as part of the role for the College of Surgeons, we play a critical role to advise the government in terms of how to stop elective surgery and therefore preserve our resources. Because with the global pandemic, a lot of the supply for drugs, medications, or even PPE are disrupted. And these are different caseload that we've seen. And most of the caseload at the moment that we're seeing are from Victoria, Melbourne. So I live in Sydney, which I'm pretty sure you know that is where the Opera House and the Harbour Bridge is, and they are still relatively low at the moment. So it's all about contact tracing. And the daily new cases recent past 5-6 days, we've been keeping a close eye on it, because I think a lot of people are happy that a lot of things are going back to semi-normal, and we've been doing a lot of cases. And I apologize, this morning I log on and log off because I have to go back and operate, because a lot of patients are demanding us doing surgery with all the backlog, and we have a lot of cancer that have been diagnosed. So it's important for us to keep going. But in this day and age, how do we protect ourselves, and how do we look at the evidence? The evidence is changing all the time. Even WHO and all the other agencies have their different way to calculate what sort of cases. And certainly, if you've seen at the moment, US is leading the pack and European are behind in terms of number of caseload. But I think the dark horse at the moment is South America. China's got it under control because they got pretty stringent control. And I believe that our Asian country, in fact, are not doing too badly, because by law, I think a lot of our fellow colleagues and etc. are very respectful, and they do have quite, even though the country can be very compact, but I think we all learn how to wear masks in public transport. We all learn how to maintain ourselves in terms of social distance. So to talk about death, because when you had a certain number of cases, there will be death, and the deaths are mostly coming from elderly with comorbidity, and obese, diabetic patient with heart problem, or patient in nursing home. So these are the things that we don't want to. And if you have patients sick, need to be monitored in hospital and ICU, it will take away your precious resources or your ability to operate on any patient. So I guess I don't need to dwell on the fact that I think this is an RNA virus. It's one of the smartest that we encounter so far, purely because of the fact that they are known or they are seen to be able to hang around surfaces and also the air for a long time. So one of the first things that when it first start happening, or when the China outbreak happened and then it's starting to spread over to Italy, the recommendation, I believe, from UK was to convert a lot of the open laparoscopic surgery to open operation, even with cancer surgery or minimal invasive surgery. So that causes a lot of uproar among all the surgeons, because most surgeons like to do the operation on what they're comfortable with, and doing an operation that they are not comfortable with, in fact, is a counterintuitive. It will create more complication. It will actually be more harmful for the patient. And imagine open surgery, the hospital stay will be longer. The risk of exposing patients to potential virus infection will be higher as well, to our belief. So we start to look at evidence if it is the case or not. And I think a lot of the study that was initially that they was based on the fact of previous surgery on HIV, hepatitis, and also some of the SARS virus that has been ravaging about 10, 15 years ago. And looking at the size of the virus, I think you also have to be really aware about what sort of plumes and what sort of sizes of viral micron that you are dealing with. And they generate particles that can be suspended in the air, and you need to completely deal with it. And different body secretion, of course, have different viral load. And I'm pretty sure that most of you are aware that the highest risk is intubations, dealing with ENT procedure or respiratory procedure. In fact, as abdominal procedure ourselves, I don't think the risk is that high. And when they consider aerosol transmission and public health, in fact, I think a lot of the time that we feel that the virus, even though it's airborne, and they may not be able to reach people if we can maintain a distance. And that's where all the evidence base coming from. In fact, a lot of people now using 1.5 meter or 2 meter, but because based on all these tests or artificial tests on how the virus being expelled by coughing, by sneezing, and using electron microscopy to look at how the suspension is. And therefore, they're coming with the fact that 2 meter distance is enough. But recently, I think they might have changed, because they can find that not only they on the air outlet fan, different toilet places, locker, chairs, there's still a substantial percentage of possibility of those particles hanging around. So I believe that it's not only wearing masks or keeping a distance, it's about cleaning, it's about surface disinfectant, which is actually another way to stop the virus. This virus requires multiple ways to stop it. And it's like basically it's an invisible war that we're fighting. And I think the initial phase, as we say, every single procedure, they're recommending full level PPE. And as a lot of countries soon find out, when you're using a lot of those gear, they run out and you cannot get a supply. So we have to rationalize in terms of what sort of procedure are high risk and whether we can delay surgery at all. But with the fact that I think delaying surgery, the other upside or other downsides will be if we delay surgery, then patients will present sicker as well. So you've got to balance that risk. So as a clinician, I think you've got to look at all different aspects, not just the scale of a protection of ourselves and the patients, but also the disease itself. So I guess with lately, the theoretical risk is actually can be demonstrated almost up to 27 feet. So this virus if you've got a super spreader that is shedding a lot of virus load, you have to look at air filtrations as well in the hospital. You have to look at how the hospital air system is being run. And different hospital will have different age of building as well. So this is the hardest part. The reason why is some hospital able to control it, or some country able to control it, and some country will be very difficult because their theaters can be very old. And in fact, I think the real life demonstration of people that is infected show that it can be up to 7 or 8 meters now. So it's almost giving up the fact if you have to social distance, you have to either do Zoom conference, or you have to yell at each other, or you have to FaceTime everyone and not seeing anyone and just hiding at home, which is not very practical. It's create a lot of other dilemma. So our surgical task force on the vice on the department are multi-level. Not surgery, in fact, is only a very small part of it. We set up community of practice and we meet each other virtually each week to discuss what's the latest development. That's including aged care pathology, anesthetic, and a lot of different level, and coordinated centrally to report to a government on how to advise the government on measures of lockdown, closing of pubs, reducing or even closing restaurant, theaters, schooling, etc., etc. These are all chain effect in terms of almost like a domino effect on how we're dealing with our life itself. I believe that when you have lockdown time, if you are gamers, you will, a lot of your son and kids are probably are, they will learn that how to protect themselves by a certain gear. So this is no different than, in fact, you should ask your children on how to play this game. If you can protect yourself with certain gear, your chances of getting infection are less. So I guess our protection, if you look at that, everyone will be very familiar that you use glove, you use cap, you use face shield, you use overall protection, or you use surgical mask or N95 mask. So you have to look at what sort of level of protection for what sort of operation. And the protection should be based on what sort of standard of care you have. And are you protecting just normal patient contact? Are you protecting on the procedure or the patient that will give you droplets? Or are you potentially protecting yourself from whether you are receiving airborne particle, which is actually going to be the hardest one? And those are the procedures that require N95 mask. Overusing it is great, but it will deplete your resources. So please be aware. And another thing that we set out to give to a hospital is you have to be aware of your locations and your hospital in terms of how many patients are in the hospital have had exposed to virus that is under observations or care, or what sort of area that you are exposed to, because it will directly affect your risk level. And you should base on your risk level to decide what sort of PPE you're wearing. So we give people simple color coding. If the hospital is low, a lot of them are green. You don't need to wear a lot of other procedure. But if it's yellow, you're in the zone that you can be exposed to certain risk. And therefore, if you have high risk procedure, you might decide to go on full protection level 3 gears. And that not only apply to yourself, but apply to your anesthetic nurse, your surgical scout, or even to students or assistants, and or even surgical rep. But most of the hospital actually stop the surgical rep from coming in just purely to reduce the risk of it. And if you have a hospital that is overrun, well, unfortunately, all you'll be dealing with the surgical emergency from the COVID patients, which you probably should be fully aware and protected yourself. So gown itself, maybe it's not the best place for us to discuss, but I believe a lot of people will be aware of that. There are even hospitals that is still using sterile gown, and that is need to be reused because they're running out of resources. Then at least you have to wear something underneath to protect yourself. So you base on what gown you wear on how much blood loss you're going to get exposed, and how much fluid you're going to use to wash the patients, and what sort of procedure are you doing. And level 1 procedures can be some of the procedures that are minor. Level 2 procedure, there may be some fluid Of course, level 4 procedures are the ones that require major trauma and a lot of splattering around, so you need full-on protection. And I believe our orthopedic and cardiac colleagues are very aware of those classifications. And I guess recommendation on healthcare worker is also important in different areas as well, because the patients can infect a person at anywhere, not only just in the operating theaters, but on the ward, on the way coming to emergency. So there have to be a system in place. At the end of the day, the goal of protection is to allow us to perform an operation safely and return the patient in a protected way, and to be looked after and to be recovered as well. I guess in terms of surgery itself, we have a straight classification. So when we first start closing surgery, we're only basically performing emergency surgery. That was done around in April time and May time, when the number was being running and we try to preserve resources. We haven't have any supply coming from China or American is hoarding procedures, so hoarding all the PPE. And semi-elective procedures sometimes can turn into dangerous thing. We discussed, in fact, is quite unfair. Alan might be able to help as well. They classify hernia surgery as elective surgery, but in fact, sometimes some of the hernia, if they are symptomatic, they're almost more than category 2, 3. They should be category 2 because they can present as a bowel obstruction and strangulation and leading towards major operation. So therefore, there's no one classification that can fit everything. But yes, bariatric surgery or other surgery that probably can, plastic surgery can be put off, we try to put off as well. So I guess with your patient classification, you got to see whether this patient is high risk of confirmed cases, or they suspected, or they in an area that is coming from high risk area that is potentially have exposures. And I guess our suggestion at that time was to slowly reopening and ramping up. We're just opening up and now we have this problem. So I believe in 2-3 weeks later, we'll have to discuss again of reducing it as well. An important thing is if we rely on patient to do things, there's a checklist that we put in place to screen patients in multiple spots to try to identify risky patients that either have the test before surgery. At the moment, we haven't mandated everyone to be testing patients before surgery because we feel that it's probably going to drain our testing resources as well. So at the moment, we're using a questionnaire as a risk basis, and then to recommend what sort of things we use in terms of what risk the patient have. So this is pretty repetitive. But at the end of the day, I think if I'm sure you're all aware that if patients are having COVID positive and having undergoing surgery without knowing it, your death rate from the China study and now from the Italy study are noticing the mortality are close to about 20%, irrespective of what operation you're doing. And Elsa, our friends, Alan and Alfred and all the other guys, and also Sutep as well, they very, very quickly has put out recommendation in terms of how we're going to approach our minimal invasive surgery. And I urge all of you guys download that and have a look at it. It's got a very good resources. I won't elaborate here. And I believe our Asian way has been doing quite well already, which I actually use that to feed that back to the department. So they're very impressed on the work that you guys been doing. And I guess comparison to all the study on whether you wear N95 mask versus all the other meta-analysis, a lot of the data are quite old. Only one study is quite new. But even that, you can see that the virus are based on Coxsackie virus, Echo virus. So we're dealing with different virus. This one is really smart, and I believe we cannot completely eliminate it. We will have to allow for certain transmission to happen because it's just impossible to completely eradicate it. At the moment, the only country that probably doing that is our colleague in New Zealand, which I guess is a bit further to swim for everyone and a bit colder as well. We only go there for skiing, I think. Well, I just want to illustrate a big example is we still have patients that we need to treat. We have pancreatitis patient that I end up doing a laparotomy in ICU to eviscerate the patient, to try to save the patients. And at the end, I think with appropriate protection. Imagine if this patient is got COVID positive, the amount of body fluid exposure to everyone is amazing. So we use ioban, we use anything that can help us to reduce and conceal the fluid exposures to staff is important. And we end up doing laparotomy to resect some bowel. The reason why the pancreatitis patient quite sick is because they end up having dead bowel on heaps of inotropes. And we have to resect some bowel, and we still manage to save the patients. But the patients spend a lot longer time. So at the moment, we have a lot of patients getting put off. How do we going to activate it? I believe we may never catch up. So in the new world, I think we probably have to choose our patients very carefully on how to operate. And our latest guideline is basically the surgeons at the moment should do what they feel comfortable, but they need to be aware of what hospital they're operating is. They need to be aware of what supply they have in the hospital, and they also need to prioritize the patients. And when they operate, if it's laparoscopic procedure, you have to have ways to get rid of the smoke if possible, or at least have the minimal exposure to our staff if possible. If you cannot do that, then if you infect one of your staff, you're gonna lose valuable staff and yourself as well. So I guess our surgeons, we have to communicate, we have to assess the risk, and that's what I want to remind ourselves. I'll stop there and I'll listen to our Austrian colleague and see how they're going there. Thank you very much.
Thank you, Professor Penloy, for that very interesting and excellent lecture. We'll proceed first with probably the questions, or after the lecture of Professor Chabie. So we'll proceed first with the professor, then after that followed by question and answer portion. So to introduce to you our next speaker to talk on the emergencies, laparoscopy. He is the chairman and the department head of clinical of surgery and visual surgery in Kepler University Clinic. He also has been a president of the Cancer Society of Upper Austria, president of the Australian Society for Minimal Invasive Surgery. He's been also board member of the European Society of Trauma and Emergency Surgery section in emergency surgery in Austria. He was also the vice president of the Professional Organization of Surgeons in Austria. Also the chairman of the Academy of Education of the Professional Organization of Surgeons in Austria. Also the chairman and head of the department, the Clinic for General and Visual Surgery, Kepler University Clinic, and also the founder of LAFCO, Training and Research Institute for Surgery and Oncology. Since 2008, he's been a member of the Professional Organization of Surgeons in Austria. Colleagues, may I present to you Professor Andreas Echelmia. Sir?
Yeah, good morning from Austria. Good afternoon to Manila. It's my pleasure to be here with you. And I say thank you to the previous lecture, which is actually the situation showing which we have to do in open and laparoscopic surgery. So before I talk only a few words on the corona, what indications do we have on emergency laparoscopy? So we have, of course, the non-trauma emergency, which is our daily business. And if you do lots of surgery, visceral surgery, sometimes also you have to do the revisional surgery, the postoperative complications, which might be done laparoscopically. On the other hand, there are also patients with trauma. You have to look in and diagnostic laparoscopy. And the most dealing situations, of course, the appendicitis and cholecystitis, a little more seldom, peptic ulcer perforation, all the large small bowel perforation, hernia, incarcerated hernia, small bowel obstruction, and the acute abdomen of unknown diagnosis. So in the acute revisional surgery, it's the three major topics: the leakage, the bleeding, and the of course bile-leak after cholecystectomy, which should be a leakage rate not more than 0.2%. So I was told that the first lecture will be extensively on COVID. So in our clinic, we have 1,800 beds, and we completely evacuated one building, which from out of 4 buildings, which completely was for the COVID suspected and COVID infected patients. And of course, we reduced the elective surgery, but as we are the second biggest clinic also, we had to do a lot, and our OR was almost 100% full of patients, only to the emergencies, which we also get from other clinics by the helicopter. So far, I had not a single member of my staff, with its closely to 200 nurses and technicians and surgeons. We had not a single infected surgeon. And I only show one short study, which recently was published on a review dealing from papers over the last 15 years, including the SARS, the SARS-2, and other infectious virus situation. And there's only a few things which you have to take care in this situation. First, all the suspected patients have to be tested. And if there's no time for testing, and if there is just the risk of infection, it's the intubation and the extubation which is at highest risk. And for that situation, all the staff members, excluding the anesthesiologist, of course, has to leave the OR. So it's only the anesthesiologist and one anesthesiological staff nurse in the OR. And after intubation, you regularly start the procedure, including special care situation, 2 pairs of gloves, a special coat, and of course, we use FFP3 mask and sometimes also plexiglass shields for the operation. The only thing which is discussed and not proven so far is the gas leaking during the laparoscopic procedure, and therefore, if possible, you should just reduce the intraabdominal pressure. We usually perform procedures with 12 millimeter mercury. In COVID suspected patient, we use 8, and we use routinely and smoke evacuation system like the air seal system. And the most important thing at the end of the operation, don't be proud how wonderful you did the procedure and just open all the trocars and let the air out. You have to suck it off with the evacuation system, and when the abdominal cavity is empty, then you're allowed to remove the ports. So in that review, they could not found really a higher infection, so they came to the conclusion that there's no need to abandon the laparoscopy compared to open surgery if you just take care on the special risk safety rules. As I said, intubation and extubation is at high risk. The smoke evacuation systems are mandatory and recommended, as well as all the other general safety recommendations. As I said, FFP3 masks and plexiglass shields. At the moment, all the recommendations popping up from different societies, even from the European Association of Emergency and Trauma Surgery, where I was part of a paper, there are recommendations now. There's no need to completely stop the laparoscopic procedures, because most of the papers and the data are on experimental basis. One word to the air seal system. There is a video, I don't know if you got it, it was on WhatsApp and all these tools showing how the virus and the CO2 is coming out. So if you use this special, it's from Ireland, this video, and if you use just the reduction cap on the port on the one hand, you have the guarantee that the virus is thicker than the particle filter. So there's even CO2 leaks out of the port, the virus is filtered, and because it's too big for the filter. So even with this video, which abandons the air seal system, the company could show that no virus is leaking out. So I want to show just a few cases when laparoscopy is still to be in favor as an open surgeon is appendectomy. We all know the advantages of laparoscopy, even in septic perforated appendicitis, because in open surgery you have a higher rate on hernia, you have a higher rate on surgical site infections, and the postoperative recovery and the length of stay is shorter. You can do it with a 3-port system. We usually do it with a single-port system, and I just show parts of videos which are prepared. You can see a phlegmonous appendix which has a perforation on the basis. It's still only 1 port, 3 instruments, and you just do the complete mobilization, and then you grab the appendix and you just staple it with a linear cutter, put it in an endo bag, and after just removing the gas of the abdominal cavity, you can very easily bring it out of the multi-port, and this is really, of course, it's the most expensive way, using a sealing system, using a stapler, using an endo bag, using a multi-port, but it's a very safe procedure. And if we move on, this is just, this was my brother-in-law, 140 kilo in weight. This video was from him, and this is the scar you see. So this is still, even in COVID-19, it's in adult, a very good and the better way to do septic appendicitis. I don't want to talk about cholecystitis because this you all know everything, but peptic ulcer is still here, even in stress moments, as in COVID-19, all the companies, the situation at home. So we have now really many patients with peptic ulcers. The incidence routinely in regular year is 200 per 100,000, and of course male are more than female. So the diagnosis is just a simple X-ray. And if you're familiar with laparoscopy in the upper and in the lower GI, you don't need more, because you know you have to operate this patient. And of course you can do the CT scan, then you might get some more orientation if the perforation is in the upper and the lower GI, and then you have 2 options. In case of a gastric or duodenal ulcer, we can suture it, we can do the resection. And these might be also in COVID time open or laparoscopically, depending most on the patient situation, but also on your surgical skills and your equipment. In very bad condition patients, it's always wise to make an omental flap. So the options depending on these 3 items, as I said previously, the most important thing for the surgeon, try to keep the operation simple, safe, and as short as possible. So the recommendation of the availabilities now, if there is a very recent ulcer perforation, short anamnesis, less than 12 hours, it's always a good idea, if possible, to suture it. If not, it's older, you have to do a refreshing of the wall, taking biopsies and then suture it, or in very fragile old patients with bad condition, just do the classic omental patch. So if it's a very huge ulcer, it might be also not possible to suture it. If it's just several centimeters in size, sometimes there is to do a gastric resection like a Billerud 2, the better option. Just a short video from a not too easy case, because this patient had his ulcer perforation at the prepyloric area covered by the gallbladder. You can see here this area, but after expositioning, and that is the most important thing, that you put 2 or 3 ports to make a good exposition of the ulcer, then you can just do a good exposition of the wall, and then take care, if it's not too big, make just an laparoscopic repair. We prefer the interrupted sutures, intracorporal sutured. If you feel comfortable, you can do also a running suture. However, at the end, it should look like this. And then we always do an intraoperative flexible endoscopy, because in Austria we're privileged to do flexible endoscopy as a surgeon ourselves, and we check the ulcer if it's tight. So Open or laparoscopically in gastric ulcer perforation, it depends on the surgeon's skills. It depends on the experience and skills of the team. And of course, if you have special equipment, generally for laparoscopy emergency and also for COVID and laparoscopy. And as I said previously, you have to have a good anesthesiologist who goes with you this way. What is the best option? I found one Cochrane review. In that review, published several years ago, they didn't do any preference. They do not say open or laparoscopically is better. It's the decision of the surgeon. And 2 years ago, there was a good meta-analysis comparing acute laparoscopic versus open repair of perforated ulcer. And they found that there's no difference in the mortality, no difference in morbidity, but the recovery and the length of stay is, of course, better in the laparoscopic group. So they suggest laparoscopy for this situation when available as the treatment of choice. Moving down in the lower GI colonic perforation, this is more common than the gastric upper GI perforation. I will show you a few examples. So this is from our clinic. All examples are from our clinic, all videos from our clinic. An old female patient went for a gastrointestinal checkup. And so this should not happen during the COVID period. So no routine endoscopy, no routine checkup for 80 years old people. So this should be abandoned in the COVID area. However, an experienced gastroenterologist, he made a perforation, and lucky him, he recognized it immediately. This does not always happen. And he didn't call the surgeon, he tried to fix it because he is used to the interventional endoscopy with the OTC clip. And this is how it looks like. And post-interventional, the patient got peritonitis. Then they called the surgeon, they made a CT scan, and they just made a plain CT scan. Then they called us and we said they should do a gastrography enema. And what we found here, I hope you can see my index, my pointer. The gastrography had a complete stop at the clip. So what the gastroenterologist did, he did not only do a perforation, he recognized the perforation, but he completely closed the sigmoid by use of the clip. So we brought the patient in the OR, and if a patient is feasible from the COVID status for flexible endoscopy, is also feasible for laparoscopy, because the flexible endoscopy is almost more risk than the laparoscopy. And I want to show you here. Here you can see the perforation, the clip, and due to a huge mass of chronic diverticular disease, which might be the reason for the perforation, we just did a laparoscopic resection, and we did just a straight anastomosis because there was no general peritonitis and the patient went well. So this is a good example for emergency laparoscopy. Here you can see the specimen. They found one review and one guideline on the management of perforation, open versus laparoscopically, and the recommendation is, if you recognize this immediately and there's no pathology, you can do just suturing. If there was a polyp, if there was a suspected tumor and you don't have any histology, you get the risk that you just suture it and leave a T1 carcinoma behind. You should do a resection. And laparoscopy, this is the consensus, is just one option depending on your skills. Next example is early recognized diverticular disease perforation, which has a peritonitis, but not a fecal peritonitis. It was just a serous peritonitis. And what we did a complete revision of the abdomen, of the descending colon of the sigmoid, and we tried to find the perforation. But this is the way how we remove the hyster, and then we did flexible endoscopy, but we do water in the small pelvis, but we couldn't find definitely the leak. So what we did is we did a lavage with beta-iodine, with clear water, and then we put a drain inside. So this, you all know, was a topic for discussion of the last year. I will just show a few slides on literature later on. which is lavage, drainage, antibiotics, 10 days in the clinic. The course was uneventful, and we did elective resection 7 weeks later without any problems. So the last example for diverticulitis emergency was a stercoral peritonitis in a 75-year-old patient. And you can see here, this is a completely destroyed sigmoid and rectum. It's a stool in the complete abdominal cavity, 4-quadrant peritonitis, bad general condition. So what we had to do, we just do the complete lavage. We did a resection. Of course, we take bacterial for the best antibiotics. We did a resection, and it's always a good thing also in these patients to then make a discontinuation. What we did is then we just put out the descending colon. As you can see, we made a classic laparoscopic Hartmann's procedure, and the patient went well. So finally, we also have to deal with revisional surgery, anastomotic leakage. And this was a patient on day 3. This is how it looks like. And if there's no paralysis with ileus, if you have enough space to go in with the CO2, and if the patient has been operated 3 days before and no COVID suspect, of course, you can do a re-laparoscopy, do a complete lavage. And again, we do flexible endoscopy and try to find the leakage, which we found on the lateral corner, on the left-sided lateral corner here, by use of flexible endoscopy. It was just the stapling line where it was crossing was broken, and we find here a small leakage. So as we don't have bad ischemia and with only a small leak, we decided to suture it by, again, intracorporeal interrupted sutures. We did a lavage, a drainage without any protective ileostomy, did another flexible endoscopy to check if the anastomosis is tight, including water inside, and then the patient got on the ward with antibiotics and went well. So what is the recommendation for free perforation peritonitis? Of course, first is to take care on the damage, make a damage control. This might be in very, very selected cases a lavage and drainage. On the other hand, if it's a very severe situation, there's a new concept, doing a resection without stoma, without anastomosis, putting in an abdominal under pressure, vacuum pressure system, and go back in the OR 2 days later, check out the peritonitis, make then a stoma or make an anastomosis. Both the lavage drainage can be done laparoscopic or open. If you make an open abdomen, of course, you can use laparoscopy. On the other hand, there's always a safe way to make a Hartmann's procedure or an anastomosis with or without protective ileostomy, depending on your skills, depending on your patient situation, open or laparoscopically. And in that situation, because the Hartmann's procedure sometimes is abandoned and you're getting bad words if you use Hartmann in the emergency situation in the night, I always like this wonderful review from 2007 from Konstantinidis. They analyzed over a period of 25 years, almost 7,000 perforated diverticulitis patients, and only these figures show 6,500 patients got Hartmann's procedure. There is still in 2020 a role for the Hartmann's procedure, and the most, as I said, as I've seen in one of the previous slides from the colleagues, nil nocere, you shouldn't harm the patient, save the life of the patient. So if you don't have any other idea, it's better to make a Hartmann than better to lose the patient. And but anyway, they state, there's a final conclusion in the paper, that if possible, anastomosis with a protective ileostomy would be a good choice. One word about lavage and drainage. This was popping up 10 years ago. 5 trials started and analyzed and showed some good results. However, one trial was closed, and the other trial, we do not know how it ended. And at the moment, we have 2 recommendations from DS Consensus 2018 that there is the lavage concept just decreases the stoma rate, but there's no consensus in the literature on an effective lavage technique, and the short-term morbidity and lethality mortality may be increasing. So the recommendation is very weak that it might be considered, depending on the patient situations, on the surgeon skills, and the surgeon should be aware that just in the idea to avoid a stoma, he should take care in his mind on all the risk and on the risk to lose the patient. So there's no recommendation on the lavage and drainage system. Few other examples: you had laparoscopic cholecystectomy, you have to go back for rebleeding. When you see a drainage in the abdomen, it's always suspicious that the surgeon had problems, because usually there's no need for routine drain in the OR. But if the patient is in stable condition, if he's not shocked, you can go in by laparoscopy. And in this case, I really like to show you the two things. There are different sizes of the suction system, 5mm and 10mm. With the 10mm, you can get all the coagula out. And we found the bleeding. It was a branch of the right hepatic artery pulsating here. So this is lucky situation when you really find the bleeding. We managed it with a clip, but the lucky situation in that case is that if I move on after clipping the bleeding, we had another problem, which we realized only due to the bleeding. We had a subvesical or an aberrant bile duct coming here. So we would have to, maybe we would have a greater problem if we wouldn't have the bleeding. So this was a good luck in a bad luck, that we've had two complications, and only due to the bleeding we had to go back. And these ducts you cannot seal, you cannot take a glue, you just have suture it. Sometimes it's also necessary to make an ERCP with a papillotomy or putting a stent. And so we could solve with an intracorporeal suture. We could suture this aberrant bile duct and put a drain, and the patient went well. So also after hernia, we had a great session on hernia today. So this is just a bilateral hernia, which really went well without any bleeding. I just move a little on. You can see no bleeding at all. We put in the mesh on the left side, on the right side. Nowadays we put in a bilateral mesh. Then we closed the abdominal cavity, and we routinely close it by the use of the Liquiband, the histoacryl glue. And there are some discussions if this really is strong enough to hold the peritoneum. Now you will see the first video worldwide to show how much power this glue will take care of, because at the end of the operation, you can see no bleeding, everything is fine. And then we've had this at the day of the operation, in the afternoon, the patient got problems with the blood pressure. He was signing of sweating, tachycardia. We had a big hematoma, but the hematoma was extraperitoneal. So the glue of the peritoneum was strong enough to hold this hematoma, and this is how it looks like on a laparoscopic way. And even in bleeding on hernia, if you're skilled in laparoscopy, you can go in back with a 3-port technique. And we found the bleeding, we removed the mesh, we put it back, we found a small arterial bleeding, which we clipped. Then we made a lavage of this area, put back the mesh, put in some hemostyptic powder, and closed the peritoneum again. Okay, so just an example on laparoscopy. So re-laparoscopy for bleeding, sometimes the surgeon gets nervous and makes a big laparotomy. If the patient is in a stable condition and the surgeon trusts himself and has the skill for laparoscopy, he's fit for surgery, and the whole team, then go back on laparoscopy. Finally, small bowel obstruction. You can also try, if there's no paralysis, go in and have a look with laparoscopy. Therefore, you have to be very gentle with grasping the small bowel, because in a rigid small bowel obstruction, you may make a perforation, which is the worst thing you can do. This is a very easy case. You can see when we just remove step by step the small bowel out of a small herniation, strangulation due to the great omentum. I can show you here after removing it completely. It was a small hole in the omentum, and there was just one cut with the sealing system, with the ligature system, and the problem was solved. So it's no need always to go in with laparoscopy. And one of the best indications is incarcerated hernia. This is an inguinal hernia. It's very easy to remove the hernia, and finally you can see the small bowel if there's a need for resection or not, and if there's no opening of the bowel, you can do just a regular laparoscopic hernia repair using a mesh, and everything went fine. If you do an open approach, you won't see the small bowel and what's happening if the bleeding is suspicious. And the last video, this is a necrosis of the cecum, acute abdomen peritonitis, and the reason was a strangulation of the ileocolic artery here. It went, this tissue just went over the ileocecal artery and vein, and made a strangulation. And because of the complete necrosis, we had to do a resection in case of in form of right hemicolectomy. So, Mr. Chairman, ladies and gentlemen, let me conclude. Many acute problems may be solved laparoscopically, also in the time of COVID, if you take the real safety issues in the OR, if you take care on patients who are suspected or not, and if you take care on all the rules which are the same for open and laparoscopic surgery. It depends mainly on the surgeon's skills. The trials on emergency cases, open laparoscopy, are by nature rarely available. However, we all know the benefits of laparoscopy. The most important issue is that the acute problem should be solved within the first attempt. If in revisional surgery, the first attempt will not succeed, the second will never do. And therefore, laparoscopy should be in your mind is one option. The most important thing is to bring the patient good at home. As I said, it's all about your skills. And if I say it's the team, it's a complete staff, including the anesthesiologists. And the recommendation therefore is to take advantage of many, many courses available worldwide. We have the box trainers in different types where you can easily use suturing, taking care of bleeding and movements in emergency situation. Mr. Chairman, let me say thank you for the invitation. It's my pleasure to be here with you. Thank you.
Thank you so much, Andreas, for a very nice lecture, very extensive one. I think we have a few time for some questions. Dr. Roel Azores.
Yes, we have in the chat box. This question is addressed to Professor Andreas. Can you flash it? Yeah.
I don't hear a question.
Yeah, there's a question at the question and answer box, and the question is for Andreas.
Okay.
The question is, do you do single layer interrupted suturing for repair of anastomotic leak? Do you have a re-leak after the repair? From Dr. Romeo Avery.
As you have seen in the most videos, we do for the most problems, we do single knot, single suture, interrupted suture by Vicryl 3/0 threads. We usually don't use the running barbed sutures, and we usually don't use the monofilament running sutures.
I think, Andreas, the question from Dr. Abari was, after repairing a leak, do you have any experience of another leak after a repair?
So we don't have it so far. We do the suturing and we check it with the flexible endoscopy. And so I can't remember so far a redo after repairing a leak.
Yeah. Are there any other questions?
Not so far. So I'd like to remind our audience, if you have any questions, feel free to post it in our question and answer box, please.
I think I want to congratulate Andreas on promoting laparoscopic surgery, because I think a lot of the people, I think they need to utilize this skill, because if you can sustain that, it will get the patient home earlier, and it potentially save your resources as well. I guess the only thing that we have to be cautious is we have to be aware of how long we're going to spend time in terms of the procedure, because under the age of the COVID, if you have to wear the full PPE gown to operate, I believe it's quite tiring and quite taxing. And I think any procedure that you know is going to be more than 3 or 4 hours or something like that, you know, maybe for the surgeon's benefit or for the patient's benefit, a quick open procedure is not a bad thing. I do share my experience with the bowel obstruction. I had 3 patients that came in with obstructions, and two of them are on a Pixaban, those blood thinners that cannot be reversed. So it's very dangerous. And sometimes one of them I got away with laparoscopic by a snip, just like Andreas did. And the other one, I did a small opening incision because the patient is quite old and 88 years old, and a small opening incision for about 10 minutes, and it's done as well with closure. So it's all about the speed of the anesthetic, whether you have enough drugs in the operating theater for muscle relaxation. There's a lot of consideration. So it's not a must, but if you can, you should do it. That's my view.
I completely agree, and we have a rule in our OR. So if we don't have a real progress after 20 minutes, then we have to do conversion. So if there is a straightforward movement of the operation, it's okay. But if there is in the small bowel 20 minutes, not a single progress, then we should convert. And I completely agree. A short open procedure is not a bad thing.
That's true. Andreas, there's a lot of issues and a lot of controversies with the use of laparoscopy in trauma. Diagnostic laparoscopy is accepted, but then again, for doing a more advanced procedure like you're trying to repair everything laparoscopically, what's your issue on this one, and what's your idea on what's your take on this?
Yeah, as I said, I tried to bring out that it's a matter of skills of the surgeon, the complete team. So I do almost 95% of my colorectal procedures laparoscopically, of rectal cancer laparoscopically. And if you are familiar with that technique, and if you're doing the training outside the OR, in the training room, then it's, to my opinion, if it's in your hands safe, why not? But if you're not in training, like the urologists, they only have the prostate cancer. They do nothing else laparoscopically. They have no small procedures for training. So for them, they might be much more difficult to do emergency surgery. But if it's your daily business, why not?
That's very true. In our center, we've been doing all our procedures. We've been advancing it from diagnostic laparoscopy to therapeutic. Even for gunshot wound, we would go for a diagnostic first. If we can do it laparoscopically, then we go for a therapeutic laparoscopy. If not, we go for an open procedure for patients. I think Ken's statement early is quite important. What's the most important thing is the outcome for patients. If you can do it so faster than an open, then you do it laparoscopically. If you can do it faster than open, then you do it in the open. I think that's a very nice statement from Ken. Ken, there's a question here from one of the participants. Please comment on the negative pressure OR and the HEPA and then the ULPA filter. I think that's the what's the usage, what's the use of, or the importance of a negative pressure OR, a positive HEPA, or a ULPA filter?
I think we look at that with the department as well. As I say before, not a lot of theaters are fitted with negative pressure. And we have an incident that we find that, yes, we can convert to negative pressure theaters, but when the air is sucked out of theaters, it dumped directly into the corridor of the theaters. So outside, so it's actually no point doing it negative theaters if your engineering and construction actually is actually probably worse because you infect all the people outside in the corridor. So it's a very sophisticated thing. And generally speaking, the modern theaters, if you can have a good conduction system, any building, I believe, or any hospital that is less than 5 to 10 years old, these are in considerations. But if your hospital are more than 10 years old, you need the hospital engineer to tell you where the air go before you convert them to negative pressure. That's one thing. Now, I also agree with Andreas. I use air seal routinely for my laparoscopic cholecystectomy, which I've been doing that for the last year and a half. And I do question them that because my fellow and me, we used to smell all the barbecue from the gallbladder, and we're asking them, is it really safe? And so that video that was shown, I believe, is the speaker actually was working with Stryker. So there's a little bit of competition going on what it is. But yes, there was some unsafeties, that's what was mentioned. But at the end of the day, the filtering system, if it's used correctly, is just one additional protection. Plus with the air seal, if you can manage to not drop any blood pressure, or not drop the pressure when you're operating and maintain a good viewing, it will help you to have a faster operation and safe operation. Hopefully can avoid all those bleeding issues. That's what happened with acute cholecystitis as well, with all this bleeding issue. And as you know, a lot of the patients in Australia, they are quite obese, and we also allow us to run the pressures on 12 or even 10, not 15. So you use less muscle relaxation and you can preserve some drugs and medication, because now we routinely use Sugammadex as a muscle relaxant to wake the patient up early and to speed up the OR. But I think there is supply issue on medication now, because we are quite far away from everything. So my next task at the moment is to advise on government how to be self-sufficient in terms of our production and supply. But there's a whole new world, that's something almost beyond our surgeons' control. So that bit I have to keep you up to date.
Thank you. We need to reserve that for another lecture, Ken. Thank you,
Alan. Dr. Erasmo, former president of PALES, is a question, I think. Dr. Erasmo?
Hi. Yeah, hi. Thank you for those great lectures. Very important comment by Professor Ken regarding the negative pressure room, because I'm working at one of the hospital, and our anesthesiologist refused for us to perform laparoscopic surgery unless our operating theaters have a negative pressure setting for setup. And we have to discuss this with our infectious control specialist. And eventually we agreed that as long as the patients are COVID negative, we can safely perform laparoscopic procedures. Question to Professor Andreas, in patients with generalized peritonitis, diverticulitis, perforated ulcers, the issue with laparoscopy is how thorough can we clean or wash the peritoneal cavity. And it's really an issue of whether we will be retaining a lot of abscesses inside the abdomen. So maybe you can tell us how do you do it, how much fluid you use to clean the peritoneal cavity, and what's your incidence of intra-abdominal abscesses following laparoscopy in these patients?
Well, there is, unfortunately, just no clear evidence about the value of lavage using 3, 6, 8, or 12 liters. So our philosophy is to use so much water and sometimes with beta-iodine till the water sucking off is complete clear. And the incidence of postoperative abscess formation, a need for CT-guided drainage or relaparoscopy is the same as in open surgery, completely the same. If you use a good suction irrigation system with pressure, and if you use the 10 millimeter suction system, you can do it, to my opinion, with the same quality as in open surgery.
Thank you.
And I believe
Very
that
assuring words.
yeah, if you add the chances of wound infection on top of open surgery as well, I'm pretty sure it's almost balanced up in terms of the risk, because open surgery is not foolproof. You still can end up with severe wound infections, which probably can be more cumbersome.
Thank you for those great comments.
There's a question actually at the Q&A box, and I think it's connected with the last question from Dr. Erasmo. The question comes from one of our colorectal friends, Joseph Roy Fuentes. The question is for Andreas.
Yeah.
We utilize lap lavage drainage as a bridge to definitive operation for high-grade diverticulitis, especially for high-risk unstable patients. What are your thoughts?
Yeah, I showed it. So we do it selectively, but there's at the moment no general recommendation that this should be the first choice. If possible and the patients are good stable, I think it's always worth to do it with a good explanation and written and orally informed consent with the patient that there might be a good chance that you can do elective surgery 6 weeks later on, but there's also a risk to go back within the next 2 or 3 days.
Thank you, Andreas. Dr. Ruel, Kuya?
Nothing in the Q&A box, I think. We had it today. Alan?
Yeah, I think we're running out of time. I think we, in behalf of our president again, Dr. Ernesto Tan, and of course the board of directors of the Philippine Association of Laparoscopic and Endoscopic Surgeons, we would like to thank Professor Andreas Shamie. Thank you, Andreas, for joining us, and of course Professor Ken Loy for joining us and sharing your expertise and knowledge to us. This 10th annual Congress, albeit a virtual Congress of the PALES. Thank you, and hope to see you soon face-to-face and share glasses, whiskey.
Looking forward to come to Philippines.
Yes, you need to come over. You need to come over.
Well.
The last time we were drinking was in London, I think, right?
Yeah.
Yeah, it was in London. Anyway, Ken and Andreas, hope to see you again. I think Amir is still with us. Amir, we hope to see you soon, face to face, and would like to thank all our foreign faculties, our special guests, for joining us and sharing this day with us. Thank you so much. Maraming salamat.
Thank
you.
you.
Thank you, Andreas.
Thank you.
Ken.
Bye-bye.
Thank you, Amir.
Thank you.
Who else is here? Thank you. Maraming salamat.
Alan, thank you very much. Galing.
Salamat, Kuya. Thank you.
We shape the future. We continue to care for the well-being of patients, and we treat everyone with respect. We are trustful, accountable, and we continuously strive for improvement. We encourage strong and thoughtful decisions, and we care about our environment. We are a 100% family-owned business with technological expertise ranging from optics, mechanics, electronics to software. We are a recognized solution provider for endoscopy, delivering customer-centric added value. We leverage comprehensive data and streamlined processes to drive our business. We are Karl Storz. And we empower individuals to become engaged employees. This is why we all come to work every day. And this is why all our customers trust our solutions every day. Because we're leading to solve core customer needs. Because we're offering a unique portfolio. Because we're acting as a trusted advisor. And because Karl Storz is living our commitment to reliability, quality, and availability all the time. With our values, our vision, and our value proposition, we shape the future. We shape our future. Starting today.